expansion, challenges in terms of funding, how do you ensure quality of FETP training, standardization of training, the curriculum, the competencies and curriculum needed to be reviewed, to be made relevant to the times that we were living in, relevant to development in other aspects of science, such as diagnostics, such as artificial intelligence, such as online learning. All right? So the global FETP roadmap clarified the vision for this global effort to enhance and expand and maintain the quality of FETP training. It defined a new conceptual framework. The Global Field Epidemiology Training Program Enterprise was coined. And there were 7 actionable recommendations for improving and accelerating progress in this FETP enterprise. Then, in 2020, came COVID-19. And it became even more clear that we needed to strengthen the field epidemiology workforce and institutions, and that became an imperative. We needed to continue scaling up quantities as well as improving quality of the field epi workforce and its institutions. Furthermore, in addition to strengthening workforce and institutions, it was also important to focus on systems and processes. What do I mean by this? So, if you look at the various national health system components that are relevant to field epidemiology, you have surveillance, laboratory, health information, pandemic preparedness and response, as well as primary health care. In addition to the systems that gird field epidemiology training, you also have processes or initiatives that are relevant to FETP, such as scaling up emergency surge capacity, preparedness and resilience for emerging threats, One Health joint plans of action, the JEE, Joint External Evaluation, and the global NCD platform, right? So from the lessons learned from COVID, it became imperative to establish structured and mutually beneficial collaboration between field epidemiology stakeholders and the partners working on systems and processes. Additional learning from COVID-19 demonstrated that it wasn't only field epidemiology trainees and graduates that were crucial for pandemic preparedness and response. There are also other cadres of staff, your broader essential public health workforce that clearly has an important role to play in pandemic preparedness and response. They all don't have to become and won't necessarily become field epidemiologists, but they need certain competencies in field epidemiology in order to do their jobs to the best possible standard and to be accountable for what they do, and obviously to reinforce their role and their collaboration. And clearly this is an area of synergy between established FETPs and these other cadres of staff that play such an essential role in pandemic preparedness and response. So why the Global Field Epidemiology Partnership? Okay, so as I pointed out, there are various field epidemiology stakeholders as you have listed in that text box. Then you also have partners, as we discussed, that are working on various systems and processes. GFEP is the ideal convening mechanism, the link that binds, okay? GFEP can map partners' activities that are relevant to field epidemiology and maintain a regularly updated dashboard. Furthermore, GFEP can oversee and facilitate the scaling up of quantities and improving the quality of the field epidemiology workforce and institutions, as well as it can align, enhance the collaboration and the coordination with and amongst partners. So what essentially will the Global Field Epidemiology Partnership do? So as I mentioned, it would scale up quantities and improve the quality of field epi workforce and institutions. It would oversee the establishment of new FETPs and strengthen existing ones. It would facilitate the updating and revision of competency frameworks and curricula. We currently have a number of partners working in that area. Quality assurance, accreditation is but one facet of quality assurance. We're also looking at self-assessments, FETP doing self-assessments. It would look at credentialing graduates. It would look at financial and programmatic sustainability for FETPs, which clearly is still a major challenge. It would look at institutionalization of FETPs into national public health systems. Monitoring, evaluation, research, learning, and adaptation is an important component of whatever activities we conduct in order to see, how worthwhile they were and whether we're moving towards attaining our goals and objectives. Network strengthening is crucial for FETPs, being network strengthening of the regional networks as well as the global network. And of course, TEFIConnect, there's a need for TEFIConnect 2.0. TEFIConnect is the online platform for FETP trainees and graduates that is hosted by TEFINET. Right. So in addition, GFEP will be responsible for alignment, collaboration, and coordination with and amongst partners. And the areas of collaboration and alignment that need to be overseen is workforce development, as we heard from the first speaker, Dr. Raji Tajuddin. We also have the WHO initiative, the Essential Public Health Functions. Singapore has now an FETP that has an urban health track, given the necessities and the context of Singapore, a city-state. The World Organization of Animal Health is busy with workforce capacity building mechanisms as well. The second big area that the GFEP would align and collaborate and coordinate is institutional strengthening. And here we're considering partners like the WHO's PRET, P-R-E-T, that is the Preparedness and Resilience for Emerging Threats. Pakistan, for example, is working on FETP institutionalization, as is Sierra Leone, and both have presented on their work. System strengthening, so the Global Fund is now funding and very keen to strengthen pandemic preparedness and response systems. And previously they only worked in HIV, TB, AIDS, and malaria. Then they moved into health system strengthening, which now covers pandemic preparedness and response. Resolve to Save Lives, we heard earlier about the 717 initiative to enhance the capacity and the response time to investigating outbreaks. APCOVE, the Asian Pacific Consortium of Veterinary Epidemiologists. And then finally, GFEP will align and collaborate and coordinate the global and regional health processes, such as GHEC, and such as the go-on responsibilities and mandate for interoperability of health workforce for deployment, and finally, the quadripartite initiative. Thank you. All right, so what are some of the key principles of GFEP? Well, clearly the space, the field epidemiology training space and the pandemic preparedness and response space is becoming increasingly crowded. So GFEP would have to remain ahead of the curve. We do know, we've learned from experience that public health interventions require multidisciplinary teams, strong institutional capacities, and of course, coordinated and aligned actions. Furthermore, these processes need to be nationally owned and internationally coherent. Okay, So you might have heard, and I'm very pleased to announce that the Global Field Epidemiology Partnership was officially launched in Berlin, Germany, about 3 weeks ago. Many of the partners who are in this room were represented or were actually present, including the next speaker, Dr. Kip Baggett. So in terms of the organizational next steps, we need to develop the bylaws for the GFEP. We also have to develop terms of reference for the steering committee, the technical working groups, and the secretariat, which will be shared between AFENET and WHO. We need to compile an inventory of all our partners and their FETP relevant activities. We need to consult our partners to inclusively develop the strategy going forward for GFEP, and then develop a costed work plan for prioritized activities. And of course, for everything that is done, we would need a key performance indicator framework. So in terms of resources, we need to develop the investment case for GFEP, and that would obviously be based on the strategy that we develop and the prioritized activities. We need to have discussions with donors on a sustainable funding model. So for example, donors could be approached to fund FETPs directly per trainee, and CDC funding that is currently routed for that purpose may be redirected to the regional networks and the global networks to support global and regional enablers. We need to plan a meeting between AFENET and all the regional networks so that to ensure that we are all aligned on our comparative strengths and complementarities, to avoid duplications in what we do, to fill gaps that exist, and to amplify our individual capacities and reinforce each other. So thank you very much for the opportunity, and there will be a question and answer session soon. Thank you once again.
Thank you very much, Dr. Carl Reddy, for telling us about the emerging partnerships within global field epidemiology. I would like to invite Dr. Kip Baggett. Kip Baggett is the chief of the US CDC Workforce and Institute Development Branch, which includes the support for field epidemiology training programs and National Public Health Institute development. He has previously served as a resident advisor in Zambia, helping the Ministry of Health there to launch the FETP. Prior to that, he was the director of CDC Global Disease Detection in Thailand. Dr. Baggett has also initiated the Global Health Security Agenda, and he's a captain in the Commissioned Corps of the US Public Health Service with a medical degree, a board-certified pediatrician, also certified in preventive medicine with an MPH in epidemiology. Dr. Baggett will speak to us about sustaining the gains of field epidemiology for enhanced global health security. You're welcome, Dr. Baggett. Can we get the slides? Are you able to get the slides? Yes. I am a Mac person.
Which one was it again?
Sustaining the gains. Sustaining the gains. No, sustaining the gains.
That's it. That's it.
This is, huh?
So one here. Yeah. So you can use this to.
Okay. Hi, good afternoon, everyone. I know everyone has been sitting in those seats for a long time this morning, but very interesting presenters so far. I'll try to keep you engaged for one more presentation in this plenary. I know folks are eager to get to the parallel sessions where the fellows are presenting. So I've been asked to talk today about sustaining the gains in field epidemiology for enhanced global health security. So when thinking about how to approach this, I'm kind of a simple person, and so I just broke it down into two areas. First, let's talk about what those gains are. I think we're all familiar with it, but I think it's worth reminding ourselves of the achievements of FETP and the contributions to global health security. And then, what are we doing and what do we need to do more of to sustain those gains, to continue those critical contributions to global health security? So, as Dr. Reddy mentioned, this experiment that is FETP really started in the late 1970s, early 1980s. Here we see a photograph that represents the launch of the first FETP outside of North America in Thailand in 1980. This was launched by the Ministry of Public Health in collaboration with CDC and with WHO, and the rest really is history. Here's a graph that clearly demonstrates the tremendous growth, almost exponential growth in the number of FETPs, and these are just the CDC engaged programs, so where CDC has had the opportunity to engage with countries to develop their programs. And this graph represents not just a growth in the number of programs, a growth in number of tiers, and a number of graduates, and you can see the alignment with public health emergencies for which the FETPs have been such a critical part of the response. But again, these are just the CDC engaged programs. This is not the full story of the breadth of FETP and the reach of FETP. Recently, CDC and AFENET commissioned some help from a contractor to do a global review of FETP to get a more comprehensive picture of that impact over the years. And this map is a courtesy of that report. Biagio Pedalino put this together. And this map really gives, I think, a better visual in some ways of the breadth and reach of FETP, where we see that 146 countries and territories have access to FETP. It's really, really a tremendous accomplishment. This really speaks to the numbers. You know, how many graduates are out there, how many programs are out there, how many countries have access, which I think is absolutely critically important. But the other important piece about FETP's contribution to global health security is what those graduates and what those fellows have actually done to strengthen public health in their nations, to strengthen their nation's health security, regional health security, and global health security. And I think the best way to remind us all of that is sometimes through stories. I'm going to start with one that's familiar to everybody here. I hope we haven't forgotten this one because it's a really important one and featured prominently in the AFENET conference in 2016 in Abuja. This is the story of the role of Nigeria's FETP as part of their larger public health response to squelch the Ebola outbreak that started there in 2014. The world held its collective breath as Ebola took hold in Lagos, Africa's largest city, well connected to other ports around the world. But thanks to a strong response from the government there and partners participating, with FETP playing an absolutely leading and critical role, the outbreak was stopped with a total of only 19 cases, which stood in very stark contrast to the tragedy that occurred in their West African neighboring countries. And here's a more recent example of a successful Ebola response, this time to Sudan Ebola virus in Uganda, just recently. These threats are recurrent, and FETPs are recurrently present in these responses. Here in Uganda, there were 52 graduates and fellows who responded admirably to this response to an Ebola virus strain that had not been seen in quite a while. So there were some new challenges to this response. The fellows and graduates conducted 176 case investigations, served as incident managers in many districts, and led contact tracing investigations in many districts to quickly stop this outbreak before there was a chance for international spread. I could tell a similar story about Ebola response in DRC, where in 2022, the first case was detected within 48 hours, which was very different than just 4 years early in 2018, where Ebola circulated for almost 4 months before being detected and responded to. FETP's contributions go beyond the remarkable outbreak response stories. And here's an example of the contributions to that core disease surveillance. And this is a heat map that could be produced, and I've seen for many countries on this continent, that demonstrates the impact of FETP frontline on the timeliness and completeness of surveillance reporting, specifically for IDSR. And although this looks complicated, really all you need to see is the flow of colors on this chart. Each of the rows represents a district, and across from left to right, you're seeing the percentage of facilities reporting to that district on time. And this time period from surveillance week 1 to surveillance week 18 is when FETP frontline was implemented. And you see going from red and yellow to predominantly green as the timeliness of surveillance reporting increased from 65% to 98%. And the story I just told in Guinea was also seen almost the same in Kenya. This is a paper that highlighted the impact of the frontline program in Kenya, not just the timeliness of reporting, but the strength of reporting, with a very nice analysis by geography, and clearly demonstrating the impact of the program and that capacity building on surveillance strengthening. And then I'd be remiss not to mention the contributions to the COVID-19 response. I think everyone in this room can think for a moment about the program's role, the trainees and the graduates responding to COVID-19. This graph depicts results from a survey that we conducted just 4 months into the pandemic, showing that nearly 100% of programs reported a prominent role of their trainees and graduates toward the towards the COVID-19 response, and these results are shown by WHO response pillar. We repeated this survey 1 year and 2 years later and found, if anything, an increase in the contributions of FETP to the COVID-19 response. I could continue with many anecdotes, many stories. Each of you in this room could probably think for a moment now about the most critical contributions that FETP has made in your country to public health, to health security, whether it's the Gambia, where there was the critical response with worldwide implications to pediatric acute kidney injury, HIV, TB, malaria, and Zambia, in many other countries, response to NCDs in many countries, including Ethiopia, I'm very familiar with. But I'm going to move on to the part of the presentation now where I talk about sustaining the gains. How have we sustained the gains, and how can we continue to sustain these gains towards global health security? And I tried to compartmentalize these into 3 areas just to help us remember them: progress, policy, and partnerships. So first, progress. This is a pyramid that you've all seen, and you're looking at this and you're saying, wait, how is this progress? We've been doing this for many years, really since the 2000s. Well, I bring this up as an example because this is and was progress. This was an adaptation of the FETP curriculum to better meet the, this thing is echoing in my ear and it's making me lose my mind. I'm sorry, let me see if I can, does that help? Ah, so much better. I'm glad you couldn't hear that. But this adaptation really accelerated the contributions of FETP and addressed those gaps in field epi and surveillance capacity that we were seeing at all levels of the public health system, and really allowed a much more rapid growth of FETP. These are the types of adaptations that we need to continue. We need to be responsive to context, to the growing and changing field epidemiology needs in countries. So let me give you a more recent example of this. And this is an adaptation to the frontline curriculum that we have been working on just recently and have begun piloting. So we have modified the standard FETP frontline curriculum to be more attentive to One Health and more responsive to the growing awareness of the importance of multi-sectoral collaboration. So this is still a 12-week program. This still addresses the same core epidemiology, surveillance, outbreak investigation principles as the more recent version of the frontline curriculum. But what we've done is to intentionally add One Health concepts, One Health principles throughout the curriculum, through the presentations, through the exercises and case studies, and through the fieldwork projects. And we've also added material to address some specific One Health competencies. We have begun to pilot this curriculum in several countries, first by doing mentor workshops, which we've done in 5 countries, serving 6 programs, including Cameroon, Kenya, and South Sudan. And then we've had the opportunity already to pilot this new curriculum, updated curriculum, in 5 countries, including Cameroon and Kenya, with South Sudan soon to come. Already 127 trainees have graduated from frontline using this updated curriculum with more attention to One Health principles. So again, those are just a couple examples of progress, but we need to continue. We need to continue to adapt. We need to continue to be responsive of the growing needs in the changing field epidemiology landscape. So let me move on to the second P, and that is policy. And this slide represents our efforts at institutionalization. Institutionalization is an 8-syllable word that is hard to say for even a native English speaker, yet I hear it said over and over and over. How many of you heard this word in workshops on yesterday, during yesterday's sessions, the pre-conference workshops? I know the one I was in, it was mentioned no less than 15 or 20 times. And this speaks to the importance at a national level of country ownership. Right here on the slide, these are 8 indicators or measures of institutionalization that we have drafted at CDC as a way to help incentivize, to motivate, and to guide countries to institutionalize programs, to work towards sustaining these programs. And although I think these measures are useful, we need to do more. We need to develop tools that are going to better assist countries to institutionalize their programs. These are national policies that are going to be critical to sustaining those gains at a country level for the country's public health priorities and national health security. At a national level, we have seen important policies that are also critical to sustaining these gains from FETP. The International Health Regulations 2005 Monitoring and Evaluation Framework specifically calls out field epidemiology training or applied epidemiology training as a way to achieve global health security. So FETP has really been codified as a mechanism, as a critical mechanism to work for countries to work towards global health security. And I just called out the indicator here, a level 4 in the detect indicator, 2 levels of FETP or comparable EPI training program are in place. Also in the IHR, we see a target. The optimal target for surveillance is 1 trained field epidemiologist per 200,000 population. That's been referenced a couple of times this morning. Another example of codifying the importance of FETP towards achieving global health security. This is a manuscript that highlights and talks about this target, where it came from, and also some of the shortcomings of this target. I think Dr. Amy Herman-Roloff today talked about some of those. As we work towards this single target, I think most countries are recognizing that it's very useful to have a target, but probably not sufficient to have that single target. One of the challenges of this target is that the existing systems to measure the field epidemiology workforce or the public health workforce more generally do not include public health workers. The public health professions are not included in current systems that classify or count field epidemiologists or public health workers like national health workforce accounts. And countries really need this, and I think we need this at a global level to be able to count in a standard way field epidemiologists and other public health workers, just the way we count doctors, nurses, midwives. It makes for development of much more meaningful targets, and also enables countries to actually be able to do this in a standard way. And so why do I bring that up? Because that kind of leads me in to the third P, and that is partnerships. I think we've heard a lot today. I mean, every speaker has spoken to the importance of partnerships. And we've heard a lot about the critical partnerships that have long been around to speak to the success of FETP with our partners like AFENET, like AFENET, like WHO, and many, many others. But here I'm highlighting a couple of newer partnerships. And this one also is WHO, but a different department in WHO. This is the Health Workforce Department that launched last year the Public Health and Emergency Workforce Roadmap. Some of you have probably heard of this roadmap that is meant to bring more focused attention to the importance of the public health workforce, including field epidemiologists. This roadmap launched with a vision to strengthen workforce in every country, delivering all the essential public health functions. And part of this, one of the action areas from this public health workforce roadmap is mapping and measurement of the public health workforce. So close collaborations, we're working with WHO to help to do this, along with many, many other partners, to be able to define the functions of public health workforce, including field epidemiologists, and get that enshrined in the International Labor Organization's classification system for occupations, so that going forward, countries can count their field epidemiologists, not just the ones who have been trained, but the ones who are actually working in a position where they're doing field epidemiology, which is something that we don't really have a standard way of doing right now. The other partnership I wanted to highlight here is a relatively new one. You just heard a presentation about from Dr. Reddy. And so I just again want to underscore the importance of this new partnership that is bringing together all of the so-called traditional partners of FETP, but the many, many other partners who work in areas and lead initiatives for which field epidemiology also is an important capacity for success. And the goal here is to bring these partners together so that we can leverage our mutual strengths to advance the progress for field epidemiology, sustain the gains in field epidemiology, and address some of these common challenges that have been here for decades to help us just rise higher and continue to that critical contribution to global health security. So I'm going to stop there and leave you with that message, but we're looking forward to any questions that you might have. Thank you.
Thank you. Thank you very much, Dr. Baggett. So, ladies and gentlemen, we have received a serving of very interesting, exciting presentations on what is going on and what is coming up with regard to global field epidemiology. Dr. Tajuddin told us about a workforce that needs to be fit for purpose. Last week I was in a workshop where they said everything in health should be made to be useful, usable, and used. So whether it's the workforce or the dashboards we are creating or the policies we are generating or the partnerships, they should be useful, usable, and used. I would like to open this up for discussion. And my first question, but I will allow members to get themselves organized. I think mics are being shared. You can put up your hand if you want to ask a question and move to the aisle nearby for the questions. And while you get yourselves organized, I'll ask my first question to Dr. Baggett. Dr. Baggett, my question is to you. Thank you very much for giving us an overview of the value of FETPs globally and what they have done and how they have responded to many emergencies. My question to you is what efforts are being done currently in response to NCD threats and how that can be used to generate lessons for other countries. But I know there are more questions coming up. Members, anyone, questions? Can we get a number of questions going? Okay, I will allow Dr. Baggett to respond to what is being done in response to the looming threat of NCDs globally, and particularly in Africa, which has been largely under the current. Over to you, Dr. Baggett.
Thank you for the question, and a really important question. And I recognize that when we talk about FETP and field epidemiology capacity, it is very often framed in the global health security context, which tends to focus more on infectious disease threats. And I think there's a couple of reasons that. One is just coming out of pandemic. It's what's on everyone's mind. And in reality, there is more funding that tends to come along the infectious disease lines to be able to support programs like FETP. Now, what I would also say is that the principles, the core principles of FETP, of field epidemiology, if you go and you look at the competencies of a field epidemiology training program, those core competencies are the same whether you're responding to an infectious disease threat or NCDs. So I do think it's important for us to continue to highlight the increasing relative importance of NCDs as perhaps the most important cause of morbidity and mortality in most countries, in a growing number of countries. But remember that those core principles, those core competencies are applicable to NCD response just as they are to infectious disease response. That is not to say that there is not value in some targeted training toward NCDs and building a workforce that has special expertise in NCDs. And so I think there are ways that we can do that as well, and we have to take advantage of those opportunities that come up. I know Resolve to Save Lives has funded some work in several FETPs around the world, including in Ethiopia, and that has allowed some kind of specialized training in NCDs. I think we need to look for more opportunities like that. And the Global Field Epidemiology Partnership is an example of one that we can use. We identify that as a priority, and this broader partnership, I think, can position us to help look for opportunities to build some of that more specific expertise in more countries.
Okay, thank you very much. I see a hand there, another hand in the middle.
I know this is rather unconventional, but may I add to Dr. Kip's answer? Just to say that, you know, AFENET has a long-standing collaboration with the NCD group at CDC Atlanta. And we know that there are NCD-tracked FETPs in Ethiopia, India, China, and Thailand. And the NCD group at CDC has developed a toolkit for use by countries, bearing in mind the significant impact that the response to COVID-19 had on NCD programs in different countries, the negative impact it had. So this toolkit allows countries to assess their NCD needs and how to address those needs. And also there are grants. This NCD group at CDC has made NCD grants available for FETP trainees and graduates to apply for. Both the toolkit and the grant opportunities are available on the AFENET website. Thank you.
Thank you very much, Dr. Reddy and Dr. Baggett. For me, it's personally exciting to know that there is already movement on that front as well. And hopefully it can be spread across the rest of the countries so that they are all moving in tandem to mitigate the onslaught of NCDs. The questions, please, make it short, 30 seconds, perhaps.
I'll repeat the question, Dr. Chima.
In the schematic he showed, there's a lot of things that is involved in institutionalization, but the final bottom line is having the foot on ground, funding the project and having the outputs. As far as using FETP is make the policies and all that, everything is important, but it's funding the FETP and getting the trainees trained and have them ready for any emergency, whether communicable or non-communicable. My question is, being in this conference now, I have had some interactions, and it's come to my notice, I don't know why, that some countries are actually, the deputy director said Kenya has had 20 years of uninterrupted. Some countries are in interruption right now, as far as information I've gathered. And that got me worried, because if this kind of situation was there when Ebola happened, it would have been a disaster. So my question is, what are we doing? It is true that in institutionalization and in transferring responsibilities from partners to government, getting government to take over, there are bureaucracies and there are things that happen. Is there any measures that as partners, as a group, that were put in place to ensure that FETP production or training is not interrupted while we are trying to make sure that the government or the countries really take proper ownership and truly institutionalize FETPs? And maybe I should have asked this first. Are we really aware, though, that there are some countries, as a group, do we know that there are countries where FETP training is interrupted? And if we do, is there a plan we're putting in place to mitigate that quickly? Thank you.
Thank you. I'll take another round, another question. There is a hand, and then a hand at the back. Then we'll first allow response to those.
It is good opportunity to us to hearing our voice in here. Doctor, he can tell you now, for example, there is more funds and, more activities in some of the countries like South Sudan, so like that. Why they doing the priorities of some of the countries, like Somalia, Somaliland? Because you remember, that area is remote area. And that her voice is not coming in here. Why he didn't make, the priorities? Because you remember, now you make, the good things, for some, the cross-border area. For some, if you do the good things in Ethiopia or Kenya like that, not doing good things or the health promoted, in our country in Somaliland and Somalia. For some, now there is the globalization. Maybe, the sick person, he come in Hargeisa or Mombasa or Hargeisa, Ethiopia, Addis Ababa. Why to make the consolidation, that countries?
Thank you very much.
So just for the speaker from Somalia, just to clarify the question then, may I just ask you to clarify the question, your question precisely? There's a speaker on your left.
I think it's clear, our question, because you remember, for example, our voice and our need, he didn't come and we didn't show in here, We want, to see and, to make the prioritized. Some of countries, for example, it's different countries. For example, Ethiopia, Kenya is high. But some of, like Somalia, Somaliland is low. Of that, why you didn't consider that countries?
Okay, Dr. Kauredi, I think what he's saying is that there should be a better prioritization of capacity building for FETPs for some countries vis-a-vis others which seem to have stronger capacity, and he doesn't seem to see that coming through. I hope I have rephrased your question. Thank you. Last question, and then we allow a response for the panelists. Please make it less than 1 minute. Be very concise.
Okay, I'll go straight to my question. So I wrote it down. So African CDC recently launched its FETP program. And my question is, how would this improve FETP program while we are considering the options of supporting member countries strengthening their FETP program or even establishing FETP programs where there are no such programs? Thank you.
Okay. I will allow the panelists to respond to the questions. Many of them don't seem to be targeted to anyone in particular, but Dr. Tajuddin can respond to it online, and Dr. Kauredi or Dr. Baggett, any of them can respond.
If Dr. Tajuddin is online, may I just ask him to address the question for Africa CDC.
No, thank you, Carl. I hope you can hear me. Hello?
Thank you, Dr. Tajuddin. We can hear
Can you hear me?
Yes, please go ahead. Please go ahead. Please go ahead. Please go.
All right. No, thank you. Thank you, Carl. So thank you for that question on Africa CDC establishing its own, and there are countries that should be prioritized either by way of strengthening their felt tip or even establishing one. So let me put it clear that the Africa CDC establishment of Africa Epidemic Service is by no means going to take away our support for the felt tip in our member states. And as you can see in my presentation, we currently supporting the Central Africa and the Southern Africa member states. That support will continue at advanced level. And one area that we have gone into now is to also support member states to put in place frontline field epidemiology training program. You know, we started that in Central Africa, and come year 2024, we're going to be doing the same in those small island and Indian Ocean states, you know, and they will continue to expand in that space. So we are doing both concurrently. And let me go to that question from Somalia and Somaliland. I think that's a very, very important question, because we shouldn't forget that there are other countries who actually need all this sort of support, and some of them seems to be forgotten. I think what I think we should be doing in that space is let's look at how do we start with something like a frontline field epidemiology training program, and which I've seen Somalia, Somaliland, Madagascar, some of these countries have started. So let's mobilize support. Let's, as much as possible, mobilize other partners to continue to invest in that space, so that, I mean, we continue to scale up capacity in that sort of regard. Now, so Chima's question, I think that's a very big one. There's no doubt about it that some countries are struggling, you know, and first some programs have been interrupted. That is no longer news. I'm sure everybody is aware. I think what didn't go well is that, I mean, let me start what has gone well. The program has started very well. It has demonstrated value. We have seen the value, but what has not gone well is the transition. You know, I think we have not gotten that transition right. You know, I don't want to blame the donors, nor do I want to blame the member states. But I think it's high time we really need to sit down as partners and look at what sort of transition mechanism will work from moving the effective agenda from donors to member states. Let's look at the way Gavi does is moving from Gavi eligible to Gavi ineligible. You know, learn a lot of lessons in that space and come and see how do we apply that to the effective enterprise. Thank you, and over to you, Chair.
Thank you very much, Dr. Tajuddin, for your response. I hope it has addressed your concerns, sir. I'll now invite Dr. Kauredi to respond to the other questions.
Thank you so much for that. You know, I'd just like to comment. I'd start with Dr. Chima's question. Dr. Chima, I don't hear you. I feel your pain. You know, I think the contradiction we are facing today is that despite the lessons of COVID-19 and which emphasize the importance of FETP training for pandemic preparedness and response, we're faced with the contradictory situation where some established funding sources are running dry. And there's various reasons for this. And I mean, from the AFENET point of view, I mean, you know, clearly the US Congress has decreased its funding to CDC funds AFENET, so that funding has reduced. AFENET as an organization is trying to diversify its funding sources, applying to other potential funders. This will also be in the remit of the GFEP. So there are plans afoot to diversify our funding, you know, to be able to to contribute meaningfully as we have done in the past. And I'm sure that these efforts will bear fruit, but I hear what you're saying, I feel what you're saying. Thank you. And then to address our colleague from Somalia, I think it's a critical question that you've raised. I mean, it's a geopolitical question, and as the director of AFENET, I wish I knew the answer, I wish I knew the solution. And we only, you know, field epidemiology is not training in isolation. Field epidemiologists are advocates for human rights at the same time. And I only have to point out to you what is happening in the Ukraine, what is happening with the war in Palestine, to indicate the discrepancies and the contradictions in geopolitics in the world in which we live and the powers that be. So I think Somalia certainly, I mean, has a point about prioritization. AFENET was approached. Whenever we do receive a request, we respond to the request. AFENET was approached for support for the establishment of an FETP at a university in Somalia. We supported, or we passed on the request to AFENET because Somalia falls within the AFENET region. And then CDC did provide support for the establishment of an FETP in the Ministry of Health in Somalia, and that support has been made available. And clearly we need to look at other mechanisms of supporting Somalia, which clearly is in need of more support than some other countries, clearly because of its circumstances. And the third point, I think Dr. Tajuddin answered that very well. And just to point out that this Africa CDC has not launched another FETP. What they have launched is the Africa Epidemic Service, which is separate from FETP, and great care has been taken not to poach recruits or not to poach from the pool that FETP recruits from, whilst at the same time providing opportunities for FETP graduates. And also Africa CDC has made a commitment to support the expansion of existing FETP tiers where they don't exist, particularly frontline. So thank you.
Thank you. Those are great responses, and I don't think I have a whole lot to add, but just to echo what Taj and Carl have already said. And just to use the Somalia example as the kind of the way we think about it, as Carl said, we at CDC don't have as much funding as we would like to have to be able to fund the great need for field epidemiology capacity building and FETPs. When we did have some funding in the wake of the COVID-19 pandemic, we did go through a prioritization exercise, and as you know, Somalia definitely was identified as a priority. I recognize that the funding we had is not nearly enough. It's not enough to continue to really build that program and other programs to where it needs to be. And as Dr. Taj said, I think this is where partnerships come in and platforms to bring together these diverse partners to understand and document these gaps and then work to help fill these gaps. And for example, and I know we're still early in this, but I'm optimistic that this is going to help fill some of these gaps. I think Global Fund has become, for example, a partner that's been more receptive to funding FETP in different countries. And the Pandemic Fund is another new mechanism where I know some countries have had some success, and I anticipate more success in the inclusion of FETPs. You know, obviously I don't have control over the Pandemic Fund, but certainly I think we are building the case as a community for the value of FETP and strong field epidemiology capacity for global health security, and that is what partners like Global Fund, like the Pandemic Fund, and others are interested in. Thank you.
Thank you very much. Prof. Serada, I'm just allowing one more round of questions and then we'll wrap this up.
Hello. Can you hear me?
2 questions.
Yes. First of all, sorry. First of all, thank you very much for the speakers. That was extremely very interesting. But my question goes to Kip. sustaining the gains of field epidemiology, and at the risk of repeating what we have, I get the feeling that many ministries of health in the region do appreciate the FTP training programs or programs similar to that. But I think we really need to put them to task that actually governments, Minister of Health or Minister of Education have to invest in Africa. And African government have to invest in the training. This is the only way we are going to sustain the gains. They have to have an investment. And I think if AFENET, CDC, Africa really needs to have some strong advocacy to the corresponding governments or ministries of health to really see a much more investment in the training of these programs. I think that is a missing piece in our sustainability. All of this training seems to be coming from all over the world, but not from the African countries. And I think that is something that we really need to show as a glaring gap for us to, to fill in. And I really hope that we can provide through AFENET that strong advocacy to make the respective governments accountable for the training. Thank you.
Thank you very much, Professor Rada. The question at the back. And then we'll wrap this up and close the discussion. Please introduce yourself.
Okay, thank you very much. Good afternoon. My name is Yaya Diso. I'm a coordinating graduate of FETP from Nigeria. I currently work with the Nigeria Center for Disease Control. Incidentally, I lead the risk communication and community engagement program for the country. And one thing that COVID-19 has shown us is the role the community plays in preparedness and response to epidemics or pandemics or whatever we call it. And in my training as field epidemiologist, we were not really trained on RCCE, but when I got to the field, when I was given this responsibility, it became very clear to me the need for FETP graduates or residents to have some skills in RCCE so that at least they will be able to be curious enough to understand the need for RCCE, and they're usually the first people who contact, whether contacts or cases, or suspected cases, and they'll be able to lay the foundation for effective communication process, and they will know how to bring in their other experts or the relevant experts in communication and when to do that. So there needs to be an investment in RCC, a drive for investment in this, and also building capacity of FETP graduates. Maybe at AFENET level and AFENET level, we need to begin to look at the curriculum and see how we can begin to incorporate this. Thank you very much.
Thank you. Seems that the two were comments. Is there one more? Okay. I don't know, Dr. Baggett, if you have final words to say, and then Dr. Carl Reddy,
Sure.
and I'll wrap it up.
I'll try to be brief so my colleagues can respond, and I think the first question, especially Dr. Taj, may have a response to. To the second comment about risk communication and community engagement, I agree with you. I think that's of course vitally important. There are a lot of demands on FETPs now, and the curriculum is pretty full as it is with the core principles and core competencies that we try to address. We hear comments like this a lot for other competencies or other skills that should be built through FETP or should use the FETP platform. And so we are trying to work through that now, recognizing that there are more skills and competencies out there that can be valuable to field epidemiologists that can fit into one curriculum. And somebody mentioned this morning the importance of lifelong learning and continuing education. I think one of the things that we need is to develop a more robust platform to house continuing education materials in a format that could be accessed by programs if a country chose to use a certain module for their current set of trainees, that would be up to them. But if not, then these materials are available to graduates as part of lifelong learning, and RCCE may be a very nice example of something like that. The first comment, I'm not sure there was a specific question there, but just the advocacy with governments to include field epi training in their national budgets and really make that commitment. I mean, I think it's a very valid point. I want to kind of cede any further time to Dr. Taj and Carl if they have a response to that or the second question. Thanks.
Thank you. Thanks, Kip. You know, just to emphasize, I agree with the professor in front and his remark about ministries of health providing more financial support. That is a challenge, but I think it's one worth looking into, bearing in mind that FETP graduates provide that vital capacity to ministries of health and national public health institutes in the interest of health security. And secondly, the question from the colleague from Nigeria, yes, as you know, there are a number of competencies that have been developed for FETP training. There are far too many competencies. So maybe in the near future, we'd look at a list of core competencies and then additional competencies that various FETPs can adopt as per their need. Thank you.
Thank you very much.
Thank you very much. Thank you very much. Thank you very much. Thank you very much. Thank you very much. Thank you very much. Thank you very much.
If you're still online,
Still online. Still online. Still online.
Yeah, no, thank you, Chair. I think for me, for the first question on advocacy, I couldn't agree more with the Prof. We need more advocacy, but we need to go beyond the ministries of health. You know, we need to bring other relevant sectors on board. Finance need to come on board. The ministries of labor need to come on board. Ministries of national planning need to come on board. Our parliamentarians need to come on board. So this is the only way we can ensure sustainable investment in health workforce. And the whole idea of having in place health workforce tax team under the leadership of President Cyril Ramaphosa is to ensure that we have this sort of advocacy at the highest political level. Thank you, and over to you, Chair.
Thank you very much, Dr. Tajuddin, and thank you for hanging in there for the whole session. We appreciate. Ladies and gentlemen, we've come to the end of this session, but I'll quickly wrap up what I've had. We have learned that to strengthen our public health institutes, we need to do business unusual. It's not the usual business. We need to build a workforce beyond the medical care, that is doctors, nurses, midwives. We need to harness the community health workforce. We need to institutionalize and build active, action-oriented partnerships, but avoid duplicating what partners are doing, rather synergize and build on each other's competencies. We need to harness technology to make data available, readily available at all levels for easy decision-making. We need to move beyond infectious diseases and incorporate NCDs, environmental threats, and others within the FETPs. We need to mobilize resources at country level for sustainability, emphasizing the move beyond only the Ministry of Health generating these resources. And finally, the need to explore mechanisms to prioritize countries which are deemed needful of this kind of support. Ladies and gentlemen, thank you very much to my panelists. Deeply appreciated for you sharing your insightful and very useful lessons, as well as expertise for this panel on strengthening public health institutions and systems for the initiatives which are ongoing. Thank you very much, and thank you very much, our very wonderful audience. And also to our online audience, thank you very much. And also to myself, thank you very much.
Good afternoon, and thank you so much. However, we are more than an hour behind in time. So we'll try to, fit in, because we still have the same time in the day. We don't have more hours, but we are more than an hour behind. So I think at this point, we are going to break for lunch. Lunch will be served in the same area as yesterday, the restaurant. Those who are staying at Pride Inn, where you had your breakfast, that's the lunch area. And we are going to try and use 30 minutes. Now, before you break off, we have some change in the rooms. Room 1 remains Shimba, as previously communicated. Room 2 remains the same, Dodori, downstairs. Room 4 remains Mwangea, that's at the reception, left of the main reception, main Pride Inn reception. That's Mwangea. However, we are going to use this room as now our room 3. So if you are planned and scheduled according to our schedule to make a presentation in room 3, do not go to Bonnie. Come back to this room. I hope I'm very clear. Yeah, so we can break at this point. Those of you who have not got coupons, our admin desk is downstairs. Pass by and get a coupon. Thank you.
first one is
One time.
picture? Okay.
Yes, yes. He's a leader. He's a leader. You can, okay?
Can I have your attention, please? May I call Deliso? Deliso, are you here? So, presenters in room number 3, can you raise your hand? Oral presenters. Okay. Okay, good. May I ask if Doreen is here? Doreen? Yeah. Evaluator, Doreen.
Oh, okay.
Doreen? Yes. Doreen? Doreen is not here. What about Joseph? Joseph? Doreen or Joseph? Doreen or Joseph? Dr. Julie? So you are the moderator? Yeah. Okay, good. So I am the room manager.
Can moderate in Portuguese.
No, no. So these are Portuguese? You are Portuguese?
Portuguese.
Okay, good, good.
No,
good.
but no problem.
Both of us, yeah.
moderate in
Yeah.
English, in French.
That's
no
fine.
problem.
That's fine. So, colleagues. So your name?
My name is
Is not here.
yeah.
But what?
Name is Dr. Julie Blake.
You.
Isn't me, is my
So
program
what,
director.
so what's your name?
And I represent here.
So what's your name? Your
Dilu
name?
Vuidi.
No, your name.
Yes,
I want
but
to introduce you.
I don't have.
Oh, you don't
this
have.
one, Yes.
So your name. Just tell me your name.
Okay.
Yeah.
I work for
Okay. So presenters, get ready. We are about to start. May I ask again if Doreen is around? I'm kindly asking if our evaluators are here. Okay, I see one. Joseph, are you around? I see Joseph as one of the evaluators. Joseph?
Where is the brother?
So we have one. It's okay. So we don't have time. We are going to start. So, yes. Okay. So, ladies and gentlemen, allow me to introduce our moderator, myself, and very difficult name, sorry. So she will tell us her name exactly. So Podie and myself will moderate this session. So Podie, welcome. The first presenter, Deliso, are you here? Deliso, you are here? Get ready, Deliso. Do we have the slides? The slides? Okay. Very good. So again, welcome to this oral presentation session. Our first presenter will be Daliso Ngulube. Daliso will give us a presentation on measles case investigation in Lumede district in eastern Zambia, January 2023. So, Daliso, you are welcome. You have 10 minutes for presentation, and then we'll have 5 minutes for answers and questions.
Pardon? All right, good afternoon, everyone. Okay, my name is Daliso Ngulube from Zambia. I'll make a presentation on measles case investigation in Lumezi District, Eastern Zambia, January 2023. So this is our presentation outline that we'll cover in this presentation. So measles is an acute disease that can lead to death. So according to studies, a sharp increase in measles cases has been noticed since the outbreak of COVID-19 pandemic. And in Zambia, most of the outbreaks have been associated with the anti-vaccination religious groups. So in Lumezi district, measles was suspected in a 2-year-old child who presented to a health facility with rash and fever on the 29th of December 2022. So we investigated this suspected case in order to confirm the diagnosis and prevent further spread of the infection. So these were the objectives, specific objectives. One, to confirm the diagnosis, to search for initial cases, to describe the case by person, place, and time, and to recommend measures of prevention of further spread of the infection. So in our methods, we had a team composition of a number of officers involved, as outlined there. It was done between the 10th to the 15th of January 2023, and we defined our suspected case to be any resident of Lumezi presenting with fever and a generalized maculopapular rash, or in a patient where a clinician suspected measles from the 1st of December to 2022 to the 15th of January 2023. Same also applied to a confirmed case. We were able to define that, and also we defined our epidemiologically linked case as a clinical case of measles that has not been confirmed but had a geographically or temporally related with dates of onset, that is 7 to 21 days apart from a laboratory confirmed case. So we also reviewed outpatient registers and established abstracted patient details. We also screened people in the community and also collected blood samples from the suspected cases. So we also collected the travel and immunization history using the case investigation form from all the suspected cases. So here are the results. This timeline just shows us the events leading to our investigation process. So as you can see, on the 10th of December 2022, there was a suspected case which we identified in the outpatient registers, but however, it wasn't reported. On the 14th of December 2022, again, we identified 2 cases that were not reported. And then on the 17th of December 2022, the first suspected case made a revisit on the 29th of December 2022, where they suspected measles, and we were able to collect the samples at this point. And then we saw a confirmed case on the 9th of January 2023, and this made us now to go flat out in the community to do the contact tracing or follow-up of these cases, and our first follow-up being on the 10th of January 2023, where we identified 8 cases, and on the 13th, we had 7 cases being identified, and on the 18th, we made the submission of these samples to a central laboratory for further investigation. So here, just showing you the social demographic characteristics of these suspected cases of measles in Lumezi district. So the child tested positive for measles on the 9th of January 2023, and then we had 18 cases consisting of actually 1 confirmed case and also 17 cases that were epidemiologically linked. So the median age in terms of the IQR, you can see that is 2 to 7, and also the median at 4. So 78% of these cases represented the males, and also we saw that a good number of these cases in Lumezi district were coming from Kajipaike, representing 89% as compared to Boma, which had fewer cases. So this is just now more details coming out, demographic characteristics, and also showing you a clinical presentation of these cases. So I think here what we saw is that we were able to have these cases classified in 2. For example, we had confirmed here by now, we had 2 cases that were confirmed the laboratory, and then also 16 of them were epidemiologically linked, and also when you check the vaccination status, we had 61% of them being vaccinated. However, 39% of them were not vaccinated. On the other side here, we can see the clinical characteristics, and what is very, very common is that most of them presented with a rash. So what we're saying is that a low vaccination coverage may have led to the suspected outbreak of measles in Kajipaike village. And then also, most important things that we can point out at this point is that we could see also some form of vaccine failure in our investigation. Cases were linked to the index case were on the rise in this community. This suggested an active infection spreading in the community. So we also made some recommendations following our discussion. We were saying we had recommended prompt implementation of targeted SEER immunization activities and also implementation of active surveillance in the community and also facility level. So study limitations, we can see at our investigation, we couldn't do a case control study due to limited time of response and also long turnaround time for the laboratory results. So the public health actions were saying targeted measles SEER campaign was conducted in the affected communities, and also we had enhanced clinical meetings on measles in the health facilities across the district. We also conducted community sensitizations on measles, So here, these are some of the sources that we were using during our investigation process. And also, in acknowledgement, we give many thanks to those outlined below. Thank you so much for listening. This marks the end of our presentation. Thank you.
Thank you so much, our presenter from Zambia. So thank you for the excellent presentation. Our next presenter is from Nigeria, and by name Bole Lawala. Bole Lawala will give us a brief presentation on his investigation on descriptive epidemiology and response to diphtheria outbreak in Nigeria. So, Bala, you have 10 minutes. So we are going to have question and answers after the presenters, after the 5 presentations to save time. You know, we are very, very behind of our schedule. So let them present, then we will have a joint questions and answers section. Bala, you are here?
Yes, I am.
Okay, thank you.
It's Bola.
Bola, Bola. Bola.
Can I go ahead? Okay. Good afternoon, everyone. My name is Bola Lawal. I'm an FETP graduate from Nigeria. And on behalf of the co-authors here listed, I will be taking us through the descriptive epidemiology of and response to diphtheria outbreak in Nigeria, 2022 till date. So as a form of introduction, diphtheria is an acute toxic infection caused by the Corynebacterium species. It is primarily a respiratory tract infection, but like we've seen in this outbreak, it could equally affect some extrapulmonary sites, such as the skin, as well as the eye. Human is the natural host for this infection, and it can be transmitted either directly or indirectly through contact with contaminated surfaces. As soon as an individual is exposed, a susceptible individual is exposed to this infection, it takes about 2 to 5 days before manifestation of symptoms, and in some cases, it could take as much as 10 days. Symptoms include symptoms suggestive of respiratory tract infection, such as fever, sore throat, difficulty in breathing, but in severe cases and suggestive of production of toxins, we could also have the presence of pseudomembrane. Diagnosis is mainly by way of sample collection via the pharyngeal or nasal swab, and culture is the mainstay of diagnosis alongside demonstration of toxin production using ELEC-TEST. The mainstay of treatment is actually use of diphtheria antitoxin given IM or IV, but there's equally a place for antibiotics therapy, depending on antimicrobial sensitivity that is being recorded. There's also a place for management of contact by way of vaccination, also prophylactic antibiotics. This slide is just trying to demonstrate the fact that with increasing or improving vaccination coverage, it's been shown that the burden of diphtheria actually decreases, and this is quite understandable given the fact that diphtheria is a vaccine-preventable disease. Prior to now, the surveillance system in Nigeria has actually not picked up cases. However, when we looked into this literature, we got to realize that there are documented cases of diphtheria across the country, suggesting the fact that perhaps this disease is there, but possibly we are actually not picking it up. And summaries from the literature search actually show truly that diphtheria is still prevalent in Nigeria, poor vaccination coverage being the main driver for this outbreak. And as at then, there was actually no access to diphtheria antitoxin, which is actually the mainstay of management, and laboratory capacity was actually very poor. And this mainly centers, these points highlighted here were the main core of some of the response activities that were carried out. The slide here more or less depicts the poor vaccination coverage for diphtheria containing vaccine in the country, thereby more or less explaining why we are currently recording this outbreak. And a several survey done in 2018 equally showed that across the country, there was actually some form of immunity gap as far as vaccination is concerned against diphtheria. On the 1st of December 2022, the Nigeria Center for Disease Control and Prevention was actually notified of a suspected diphtheria outbreak, mainly in Kano and Lagos. And for those that actually understand the geography of Nigeria well, these are two states that you will never want to have an outbreak. Upon receipt of this notification, we set out to investigate the outbreak with the following objective. First is to actually confirm the existence of the outbreak, determine the epidemiology of the outbreak, and based on the findings, institute appropriate control measures. We use the WHO case definition for diphtheria, which actually states that any person with illness of the upper respiratory tract and with the following symptoms: pharyngitis, laryngitis, tonsillitis, and presence of the adherent pseudomembrane qualifies to actually be a suspected case of diphtheria. While a confirmed case is any person in which corynebacterium species is actually isolated by culture, and further tests actually demonstrate toxin production. And we equally use the WHO final classification to be able to actually classify the confirmed cases, which are largely the laboratory confirmed cases, epidemiological linked, and clinically compatible cases. Discarded cases were referred to those cases in which either the corynebacterium species was not isolated, or it was isolated but toxin production was not demonstrated. We reviewed the surveillance data both in health facilities and communities, as well as conducting active case search. We collected appropriate sample, nasopharyngeal as well as oropharyngeal swabs, and based on these, we actually did laboratory confirmation by way of culture and ELEC test, with PCR also used to complement the ELEC test. Antimicrobial sensitivity test was done, given the fact there is a bacterial infection, and in the light of AMR, it's important for us to know the prevailing susceptibility of the organism to commonly available antibiotics. Furthermore, we conducted descriptive analysis to actually describe the outbreak with respect to person, place, and time. These are the findings from our investigation. As at Epi Week 42, which is kind of 2 weeks back, this year, a total of 14,125 cases were actually suspected, and these are the classification of the final classification of these suspected cases. 63.9% of them were actually confirmed. And going by the various sub-classification for final classification, we further went ahead to actually distribute this, and we realized that about 2.4% are actually lab confirmed, epi-linked 0.3%, while clinically compatible cases constitute the majority of the confirmed cases. This is trying to show the incidence across the states, and Kano State, being the epicenter of the outbreak, has an incidence of about 531 cases per million population. And while Yobe State actually follows suit, and we can see the incidence of others as displayed on the screen. The national incidence currently stands at 44 per million population, and these 4 states, Kano, Yobe, 5 rather, Kano, Yobe, Bauchi, Borno, and Katsina, actually account for 99% of all the confirmed cases recorded so far. So this is actually the epi curve. It started way back in December last year. Shortly after then, we experienced the first wave. Shortly after then, we experienced the first wave, which more or less tapered. It's not working again. It's not working again. Okay, it's working now. Okay, sorry about that. So the outbreak actually started way back last year in December. Shortly after that, we recorded an upsurge in number of cases, and this actually tapered, and at about Epi Week 21, we thought the outbreak was actually declining. Subsequently, we now experienced an upsurge in the number of cases, which actually marks the beginning of the second wave, and from the graph, you can actually see that in terms of magnitude, the second wave currently actually is much more than the first wave. It started with a rapid increase in number of cases, but the good thing is that currently we are experiencing a form of decline in the second wave, and we hope we should be able to sustain this. Looking at the trend of deaths as well as case fatality rate, during the earlier part of the outbreak where we had limited access to diphtheria antitoxin, the case fatality rate was actually quite high as an average of 40%, but with improved access to diphtheria antitoxin, which is actually the mainstay of management, and we've been able to actually bring down the case fatality rate, and currently the case fatality rate is at 5.6%. And just like we are recording a decline in the number of cases, we are equally recording a form of decline in the case fatality rate as well. And this slide actually shows the distribution or the contribution of each of the states, particularly the high burden states, to the current outbreak that we're experiencing. And as you can see, Kano State, which is actually at the center there, accounts for over 80% of all the cases, and hence being termed as the epicenter for this outbreak. Looking at the age-sex distribution, we have a preponderance of the female sex, particularly as the age moved towards the age of reproductive age group, above 15 years of age. And we've observed that female are much more in population as compared to the male. And this is likely due to the fact that females of this age group are the one responsible for caring for patients, and going by the modes of transmission are more at risk of getting infected, and perhaps that explains that increase in the proportion of cases amongst female. However, we're looking at the age-specific and sex-specific case fatality rate. We observe the kind of switch in pattern, with male actually accounting for much more case fatality as compared to female, and it is even definitely higher by the time the age exceeds 40 and above. Being a vaccine-preventable disease, we equally examine the vaccination coverage of cases, and we observe that children that are actually unvaccinated, have not received any single dose at all of the diphtheria-containing vaccine, account for more than half of the cases. And this slide actually shows the antimicrobial susceptibility pattern, and from this we can clearly see that most of the cases are actually susceptible to erythromycin. With respect to response activity, in terms of coordination, EOC activated. In terms of surveillance, we've been able to develop tools for vaccination. In terms of reactive vaccination, we are currently in the second round of reactive vaccination in the country. In terms of laboratory, prior to now, there was no capacity in country to confirm diphtheria, but now we're able to do that at the national level, and we went a step further by building the capacity of the subnational labs to be able to do that. The states in green are states where the labs there have actually been optimized to be able to do some form of preliminary test for diphtheria. In terms of case management, we've been able to improve access to diphtheria antitoxin as well as IV erythromycin, and setting up of treatment isolation centers. With regards to risk communications, we've been able to develop and disseminate social and behavioral change communication materials. In conclusion, for the first time in over 2 decades, diphtheria outbreak was actually confirmed and responded to in Nigeria. Suboptimal vaccination coverage was identified as the main driver for this. We strengthened laboratory capacity, improved access to diphtheria antitoxin, conducted reactive vaccination, as well as sensitized healthcare workers and community members. We recommended strengthening of routine immunization coverage, as well as formulation of diphtheria booster dose policies in Nigeria to close that very gap that currently exists. Thank you for listening.
Thank you, Bola. Again, presenters, please make sure you stick to your time. Your time is 10 minutes, so try to finalize your presentation within 10 minutes. The next 3 presentations will be moderated by my sister, Dr. Podi Dilo. Sorry for mispronouncing your name. So, Dilo, you're welcome.
Okay, good afternoon, everyone. I speak in French. For this, to continue the section,
I'm going to invite Abdoulaye Gobagoye. I hope I have well pronounced his name. He's going to present the work of investigation of measles in Tiberi, Niger. Thanks very much. So, my name is Dr. Abubakar Abdullahi. FETP Burkina Faso. I have the honor to present to you my work on investigation on measles in Tiberi. This is an infectious disease, very contagious, and it's endemic in different countries of the world, which brings about mortality and morbidity in children, especially where we have poverty. Each year, 100,000 people die because of measles, against 2 million before vaccination came around. This is to say that it's very important to vaccinate the children because the vaccines are working. In 2019, 10 million cases were noted, and this brought about 217 deaths. In Africa, we have quite a number of deaths registered in 2018. In Niger, we have measles because we don't have good coverage of vaccination. 2019, we've got to say that we had 46 cases. In 2022, the half of the districts of the country had one case at least. In Tiraberi region, in 2021, we had 194 cases. A confirmed case and other suspected cases were reported in this region. That's why we carried out an investigation to confirm the presence of these measles, and we had to analyze also where we are with the coverage of vaccination. This area is at the northern west part of Niger, where we have Mali, Burkina Faso, and Benin somewhat. 3 million thereabouts as the number of the population. Methods. We carried out a cross-cutting study 2021-2022 to see the population in Tiraberi. Source population, these are people from the affected districts. In this investigation or study, we did an active research with people working on the ground, the community relays and health workers in the district, so that they give us case definitions, and through this WHO definition, we had to contextualize this. We had data collection, and we used AP-Info to calculate with an interval of confidence, the ratio, the median, with the interquintile. When it comes to case definitions, this is anybody who is staying in Tiraberi, who is showing fever and rashes, or somebody who has been suspected by a qualified member of staff. Confirmed cases, these have been confirmed at the laboratory level. Suspecting this epidemic, we are talking about a cluster of 5 suspects in a locality during a month. When it comes to confirmed epidemic, this is defined as 3 cases that have been confirmed by the laboratory in a locality during a month. The results I'm presenting to you are coming from our objectives. So our first objective is to confirm the epidemic. And in this graph, you see weekly progress of measles in Tiraberi. We have confirmed cases, then we have red, which constitutes the threshold, 3 cases confirmed in a locality during a month. So in this slide, you see that the Tiraberi region was in a problem since the week 8 when we had started our investigation. Case distribution by gender, the male is dominant with 1.38. Distribution here, according to age, shows that a majority of our cases is 5 years or more. The median age, 6. Distribution of measles in Tiraberi shows that more than 80% of our cases, maybe they were not vaccinated or their vaccination records are not known. This figure shows us the cases of measles in Tiraberi. We have the epidemiological weeks and then the number of cases here confirmed at the laboratory or suspected. We realize here that the epidemic started at the 5th week and the peak was at the 14th week. .07 for 1,000 inhabitants, but this goes down from district to another. The description of these cases, measles cases, as represented in this slide, on the map, you are going to see that these are neighboring districts of Burkina Faso and Mali. When we did more analysis, we realized that these districts were much below, even when you consider the national targets for fighting against measles. The discussion part of our presentation in our study, more than 70% of those ones are affected by measles. They are either 5 or 5 years and above. Median age, 6. This region of Tiraberi, since 2016, 2017, there was insecurity, so that even those ones who are doing vaccination, their services were interrupted. This is what we can have as an explanation for this phenomenon. So our results are in tandem with the WHO report of 2020, talking about 5 years as the average age. And another study carried out in Mayotte shows this. In Mali, the age of the children was, the majority of the affected children was 5 or below. Males are much more affected in our study. This has been done as a study in Sudan and Mali, and they show the same trends. In our study, we found 0 fatality. We estimated that in our study, the majority of children have 5 years or more, and fatality for children below 5 years is much more common. And these were in peri-urban areas where they don't have the necessary access to vaccination. We carried out sensitization, advocacy. To conclude, we can say that a majority of these children affected by measles, they are around 5 years old. And the majority of them, either they were not vaccinated or their records are not clear. And we need to do much more surveillance. I thank you very much for your attention. Abdoulaye, merci beaucoup. Thanks very much. I'm going to invite Sani Salfa Isaka. He's going to present their work on measles in Dongao, in Benin, 2017-2021. 10 minutes. Ladies and gentlemen, the members of the jury, dear participants, hello everyone. Salfo Esakasani, coming from Benin, I have the honor to present to you the epidemiologic profile of measles in Donga Department in Benin, 1st January 2017 to 31st December 2021. After introduction, we are going to present to you the methodology of our work, the results, and we are going to end with a discussion. As an introduction, we say that measles is a viral disease which is very contagious, but that can be prevented through vaccination. And man is the host. In Africa, and according to WHO, 17,500 cases were recorded in the first quarter of 2022. There is necessary treatment that is needed, and this is a major public health issue. WHO says that 119 million children were vaccinated in 2019, and this reduced to 84% the deaths linked to this disease. This is a problem. It is a problem which causes deaths amongst children in the world, especially in Africa. It causes a lot of child mortality in Africa, where we have deaths for 5-year-olds and under. In Donga, we had outbreaks in 2018. Using the definition of cases and the thresholds, this allowed us to come up with work to fight against measles in Donga Department in Benin. Objectives: we need to determine the epidemiological profile. This goes from 2017 to 2021. We need to describe the socio-demographic characteristics of the measles, describe the epidemic in the department. As you are able to see, we're talking about the Republic of Benin, which has 12 departments, and Donga is amongst these 12 departments with the density of 62,000 square kilometers. We have 72 peripheric health centers. Our study was a descriptive study. As a population of study, we wanted to see all the cases which were reported through the time frame of 2017-2021. We used the case definition and talking about here anybody who presents a rash, a fever, or conjunctivitis. Sampling, we analyzed data using QGIS, and we calculated the incidences, frequencies, and proportions. Results. Total number 134 as confirmed or suspected cases, and we see that for the children it's 1 to 4 years, and the ratio 1.3, and we concentrated in the rural area. Njugu and Basila had the most of the cases. The result of our result number 2. This is the distribution by year. So each year and the number of cases. The number of cases went up 2017 to 2018. And this explains that given the vaccination campaign we organized, we were able to note that the cases went down drastically until 2019. Result number 3, this is case classification for 2017-2021 in the department. Here, we are able to say that 47% of the cases were confirmed by epidemiological link or confirmed at the laboratory. Number 4, these cumulative incidences, when we talk about the localities in Donga department, Jugu has many more incidences with 13 cases for 100,000 inhabitants. 5, this is by age. 52, this is 52,000 for 100,000 cases. When we talk about vaccination history, we see that those ones who have not been vaccinated are affected more. And finally, here we have a mapping of 2018, where we realize that it's only Wake which was not affected. The other localities had epidemics. Discussion, the ratio by sex 1.43, and this is similar to Bashab and Mauritania in 2017, and Togola in Mali in 2019. They obtained 1.3 as the sex ratio. The vaccination status for those ones who have not been vaccinated, the incidences are high. And this is reflective of Dushi in Niger 2018. In conclusion, we could say that we still have the measles in Donga. The majority, those are children less than 5 years coming from the rural areas and are not vaccinated. Intensification through vaccination, having campaigns, is going to allow us to reduce these incidences. Recommendation. For the centers, they do surveillance and they reinforce coverage. These are some references of our study. We need to thank the Ministry of Health in Benin, AFENET, CDC Africa, Atlanta, mentors, and your comments are going to help us to improve this work. I thank you very much indeed.
Know if Doreen is in the room. Doreen, okay, thank you. Okay, pour continuer.
To be able to continue, I'm going to invite Mr. I hope it's a Mr. Ahmed Abala is going to present investigation work of measles in hospital Balbala, Sheiko, Djibouti, June 2022. You have 10 minutes, sir. Greetings, everyone. Ahmed Rufa Abdallah, FETP, Djibouti. My work Greetings, everyone. Ahmed Rufa Abdallah is my name, FETP, Djibouti, Cohort 2. We are dealing with investigation in a hospital in Djibouti, June 2022. How I'm going to proceed with my presentation, as you see it. And this is a very contagious disease caused by a virus of paramyxavidae. At the 24th week, 4 suspected cases were noted in Balbala Jeko, and we carried out an investigation. We have a surveillance team, NSPD, residents, mentors of FETP to confirm this disease and come up with a scope of where we were with the disease. To be able to put in place control and preventive measures and propose solutions. This hospital is a referral hospital which has 359 beds, service area 30,000 meters square. The population served here 318,530. To get to our objectives, we carried out a descriptive transversal cross-cutting study going from 19th June to 4th October 2022. Population of study for all cases confirmed, suspected cases in the catchment area of this hospital. Exhaustive sampling for all the cases that have been captured during the study period. Suspected cases, anybody who has fever, rash, associated to coughing, or conjunctivitis that has been notified in the hospital during the period of the study. Confirmed case, positive ELISA, or having an epidemiological link to a confirmed case. We carried out data collection. We went through desk review, looking at the records, consultations, records from the laboratory, with interviews at the community level, dealing with interviews. And there was an active research that was carried out in the hospital and the community. We carried out data analysis using a software, SV20. We calculated the frequency and the rate of ratio. Here are the results. 92 cases were notified, 37 confirmed, EGM positive, 55 cases confirmed through the epidemiological link. Median age, 12 months. The least 4 months, and the highest 9 years. 1993 cases with less than 5 years. Attack rate, 29 cases for 100,000 inhabitants. Mortality, 0, no death. This is a table that represents the socio-demographic cases. We need to emphasize here that 68% of these cases were not vaccinated. The most affected, less than 5 years. Males are affected more than their counterparts. This is a graph that talks about the weekly progress. The 24th, 25th week and 35th, 36th week. This is the peak of the week. This diagram shows the different signs with the rash and fever. 100% of the cases were taken care of by the investigating team, and we carried out some sensitization sessions that were thematic so that people get to know the importance of vaccinating children. And more women were represented in these sessions of sensitization. For this work, this problem of measles affects more for children under 5 years, and the majority of registered cases were not vaccinated. That is why we are recommending vaccination of children of less than 5 years, rather, and the sensitization of parents on the importance of vaccination, and to carry out a detailed study in Djibouti. Actions to be taken. We take care of the confirmed cases. We investigate further the suspected cases, and the sensitization of the community on the importance of vaccinating children under 5 years, and of course the health staff to be sensitized as well as on how to take care of the cases. Some references here, and these are our acknowledgements, and I thank you for your attention. Très bien. Merci.
Moderating the Franco presentations. I think I realized that we need to learn French. It has been difficult. So, ladies and gentlemen, we are coming back to the English presentation, and our next presenter will be from Zambia. So, Tadelo Kolobe. Tadelo Kolobe will give us a presentation on measles outbreak investigation among vaccinated group in Zambia. So, Todole, you are welcome. Over to you.
Thank you and good afternoon. My name is Tebelo Kolube, and I'll be presenting to you measles outbreak investigation among anti-vaccination religious communities in Sinazongwe and Pemba District, Southern Province, Zambia, 2022. This is the outline of my presentation. Measles is a vaccine-preventable disease, yet it remains a public health threat in Zambia. Normally, outbreaks in Zambia happen among anti-vaccination religious communities, and several outbreaks have been reported in the country. The WHO recommends 95% vaccination coverage in order to prevent measles. On the 1st of August 2022, Sinazongwe Health Center reported a suspected case of measles. This was an 8-year female presenting with rash, fever, and cough. Between the 15th to 25th of August, 9 suspected cases and 3 laboratory confirmed cases were reported from the same facility. And this was coming from a community that is dominated by a religious sect that eschews vaccination. An investigation was conducted on the 30th of August to September 5th, and the objectives were to identify additional cases, assess the vaccination status and associated factors, and recommend control measures. We reviewed the health facility registers and medical records, conducted active search and interviewed cases and controls. We developed a line list of all the cases and followed up on laboratory records. Oral consent and assent were obtained from all the participants. We also extracted data from the DHIS2, the District Health Information System for vaccination coverage for the 2 districts. A suspected case was defined as any person from the affected communities of Pemba and Sinazongwe districts presenting with fever and maculopapular rash and coryza, cough, or conjunctivitis since July 26, 2022. This was based on the incubation period for measles. A confirmed case was a suspected case with positive IgM antibodies or epidemiologically linked to a lab-confirmed case. And a measles death was defined as any death that met the case definition with or without comorbidities. Sinazongwe and Pemba district are found in the southern province of Zambia, and the main source of living in this district is farming and fishing. For data analysis, we conducted our analysis in R and conducted a descriptive analysis. We also calculated the case fatality rate. And since we wanted to establish the association of different demographic factors with the vaccination coverage and vaccination status of the cases, we conducted the Fisher's exact text. We also calculated the adjusted odds ratios for being vaccinated among the cases at 95% confidence interval. So on our findings, between the 26th of July 2022 to September 1st, there were 132 cases that were identified, and among these cases, there were 9 laboratory confirmed cases and 123 epi-linked cases. Although the index case came from Sinazongwe, based on the findings, we established that Pemba had earlier cases. And according to the line list, the case fatality rate was 13.6%. That is way higher than the recommended. Okay, thank you. Based on the signs and symptoms of the cases, all the cases developed rash with 99% having fever, and coryza only had 38%. So from the 32 cases that were line listed, we interviewed 81 cases with 27 coming from Pemba and 54 from Sinazongwe. So based on the socio-economic factors, socio and demographic factors, what we identified was that 53% of the cases were males, and 62% had primary education, and 81% in terms of religion were from Old Apostolic Church, that is commonly known as Zionist in Zambia, or Kumbule Kaya. And again, when it comes to the travel history, 85% of the cases had no travel history, and with symptomatic visitors, because we wanted to establish if there had been any visitors to the cases, we established that only 22% had had visitors before and during the time of the outbreak. And for the factors associated with measles vaccination, what we established is that religion other religion had a significant association with adjusted odds ratios of 26.5 at a p-value of 0.07. Same with knowledge about measles. What we established is that most of the 16.5, having knowledge was 16.5 times higher for cases to be vaccinated, and this was significant at 0.02. And for the public health interventions, Sinazongwa district conducted the mass vaccination and 4 cases were referred for health facility management. We also conducted counseling among mothers and caregivers for all the affected cases. There was also a risk communication that was done during the investigation. So for the limitations, we must admit that there were limitations in that not all the cases were interviewed during the investigation, and some of the cases were not available. Another thing that we did not do was to evaluate the impact of vaccination that was conducted during the investigation. And we did not establish the source and transmission of the outbreak. As a way of conclusion, what we have seen is that the anti-vaccination beliefs, particularly for religious groups, has exacerbated the measles spread. And the case fatality, like I indicated, was twice as high as expected. And belonging to a religion other than apostolic or Kumbleka, like I indicated, as well as having knowledge about measles, increased the chances of being vaccinated among the cases. And one thing that we recommended was, in order to be able to know the transmission paths and the cause of the outbreak, for measles, there has to be a genomic sequencing for measles. And also, what is also important is to engage the anti-vaccine communities to raise awareness about vaccination. And I'm glad to mention that the country has already embarked on this one. And again, it is important to promote complete vaccination at start of elementary school so that kids have completed the vaccination before they are in schools in order to reduce the transmission, and also for the country to be able to reach the Agenda 2030 and prevent future outbreaks. These are my references, my acknowledgements. Thank you.
Thank you, Tebelo, for your presentation. You economize 1 minute. For time, we permit 1 question for each presenter. For the audience, 1 question for each presenter. Pour l'audience,
Just 1 question for each presenter. We have gained on time. Yes, sir. Thanks very much, Madam Facilitator. My name is Sidibe Toumani. I come from Mali. My first question goes to the brother from Niger. In your presentation, you said that the districts that are neighboring Mali and Burkina Faso are much more affected with a very low vaccination coverage. Which were the actions carried out to deal with this coverage when you talk about neighboring districts with the 2 cited all countries you spoke about? For our brother from Benin, you spoke about commonalities between your study. I'd like to know did you carry out a statistical test so that you can talk about commonalities? Is it a statistical test that you carried out? We'd like to know. And the last speaker, these associations against vaccination, you talk about they have exacerbated the situation of non-vaccination in your country. What has been your action? We know that these associations against vaccinations, they exist. So we'd like really to know what you've done to deal with such anti-vaccination organizations.
Sheriff from Sierra Leone. I want to thank the presenters for the wonderful presentations. I have a little bit of concern for Abdoulaye from Niger. You said you investigated a measles outbreak. And in your introduction, you mentioned about low vaccination coverage. But in the entire work, I didn't see you present anything on a vaccination coverage survey. And you went further to conclude on low vaccination coverage when you don't have any information on that in your results. So I want you to clarify that.
Two questions. Yes. Question for Djibouti and...
OK, merci beaucoup.
Thanks very much. Dr. Marichan from Chad. My intervention is not a question really, but rather a contribution, because we have the same problem in our districts. And this is maybe going to enable us to tackle the vaccination coverage. I think it's Niger that talked about weak coverage, and this is due to insecurity. If you know the problem already, that there is low coverage, you need to intensify actions in this sense. If a partner comes and says, you have detected what the problem is, insecurity is explaining this, and you solve the insecurity problem, is it possible now that the coverage is going to be improved? Back home, I can't really say yes, because the low coverage is not linked to insecurity alone, but human resources aspect as well, because we have responsibility zones which are very, very big when it comes to the density and the service area. One person who is not qualified, without help from other colleagues to do vaccination, it becomes very hard to have a good coverage. This is one thing to note. And then means of moving around. For those ones who are doing vaccination, we have a fixed strategy and an advanced. We talk about more than 10 kilometers. And when you are mobile, you can go to 15 kilometers. You can't do 10 kilometers on foot to go vaccinate children. So partners need to support us, maybe give us boats, motorbikes. And sometimes we have Boko Haram insecurity-related issues beyond mobility. Then there is motivation. Motivation, here I'm talking about you cannot go or vaccinate people without getting something back. So sometimes it's very hard to have a good coverage. And people don't know the vaccination calendar. They say it's done twice a year back home, for example. And this can explain the weak coverage. We need to add this beyond the insecurity that you spoke about. Question? Question? Nigeria already? Has asked a question. Dr. Ilbegu from Burkina Faso, I remain seated. You spoke about diphtheria, and thanks very much for your good presentation. What type of surveillance have you put in place? Because you said that this is among epidemics since 20 years. And then you spoke about associated factors. This is for Nigeria. For Djibouti, you need to clarify to us. You said that in the methods, you did active tracing of cases in the hospital. You need really to be clear on that, tracing cases in the hospital.
Merci.
Thanks very much. Dr. Mbongo from Gabon. My question goes to Zambia. The last presentation, which was very interesting. In your study, I saw that you have a number of associations, some associations. I'd like to know what were the adjustment factors and for these associations, which are significant, what were the actions that you have carried out? Do you look forward to deepen your study so that you can help this community which is anti-vaccination? The presenters, I turn to you to answer the questions that have been raised. Thanks very much. I thank those ones who have followed my presentation. I thank very much those ones who took the floor to ask questions, those ones who gave their contributions as well. I thank you. Those ones who have presented this morning, they come and thanked the government of Kenya for this hospitality. I am really very, very grateful to the people of Kenya. The first question is about actions that have been taken when we talk about the districts affected by measles, neighboring Mali and Burkina Faso. In the definition of our study scope, I spoke about insecurity issues at the border level. And Tiraberi, as a district, it's neighboring the three countries. From 2017, we really know a lot. We are going through a lot of insecurity. Many health centers in Mali, in Burkina Faso, in Niger, at the border level were closed. And this explains that vaccination services, routine services, are not available. As an action that has been taken, measles has been detected amongst those people who are in movement, who are leaving this country, going to the other. When the cases were reported, we started with the partners, military partners actually, the army, because they have the health sector or section in the army. The military people took their personnel, given the insecurity issues, and this is how we were able to fight back measles. The other question on weak coverage, I spoke about, and you were able to see it on my slides. You need to see that since 2012, this coverage, somebody spoke about the vaccination calendar here. We have 2 doses that are necessary so that we fight against measles. Since 2012, we didn't go beyond 72%. And for the second dose, it's 58%. So it's true that the countries are the same, yes, but they don't have the same problems. There is a speaker who spoke about insecurity, human resources, etc. In Niger, we have the logistical means, human resources, and then with some funding from Gavi, which really does a lot to do vaccination. The only challenge that we have realized is that there is inaccessibility of these regions. Gavi gave motorbikes, vehicles, per diems to take care of the community relays, those ones who are dealing with vaccination. But the question of insecurity is there. We can't do much because this is a constraint.
Thank you very much. The question asked, you talked about, or asked rather, what surveillance was put in place, and given the fact that this is the first time in about 20 years that we are actually responding to such an outbreak. So essentially, the non-indicator-based surveillance that we're used to, and the routine indicator-based surveillance, where we rely on routine reporting as well as active case search in health facilities and communities. However, what more or less is different this time around that perhaps made us able to pick up the outbreak was mainly around the high index of suspicion that the clinicians in these health facilities actually had. Evidence has actually shown us that diphtheria is actually out there for quite some time, but we've not been picking it, partly due to the fact that clinicians are actually not aware. You know, diphtheria is something that we've all forgotten about, so to say. In the IDSR guideline, Afro, it wasn't even mentioned as part of the prioritized diseases. In the Nigerian IDSR guideline, it was just mentioned in 2 places, and it was just in passing. For most of us that recently graduated from medical school, you will agree with me that we hardly even saw a case of diphtheria. So diphtheria was something that virtually everybody had forgotten about. But it took that high index of suspicion from these clinicians for them to actually think about it, and they were able to draw attention to it. The other thing again was that prior to now, the laboratory capacity for confirmation was not there. Even from the previous studies that we're seeing, the only confirmed case that was actually identified sometime in 2016 in Borno was even diagnosed even outside this country. But thanks to NCDC and with support of partners, we've been able to build the capacity in country, and now we're able to confirm it, and perhaps that is what is responsible for why the surveillance system is better and we're able to pick and respond to these outbreaks. Thank you, and I hope I've been able to address the question.
Thank you so much, and thank you for the questions. I think I had one question that was asked by 2 people about the interventions that have been put in place since the outbreak. I must mention that one of the things that was done by the ministry was to fully engage the religious leaders and community leaders in planning for supplementary immunization in the affected districts. This was a priority in the country, and it has been done. I can provide the statistics later, but I must mention that the coverage was very good after the supplementary immunization activities that were conducted in those affected areas and other districts that had outbreaks in the past. And prior to those, one of the things that has been strengthened is community engagement. There's been sessions on health promotion and health education activities among those populations so that they understand and appreciate the importance of vaccination. Thank you.
Merci. Thanks very much. And thanks very much to all the participants for the interest that you've had for the different presentations. The only question that was asked to me is the commonalities of the studies. In our study, we have to say that we calculated the intervals of confidence that allowed us to say that our results are similar to others' work that we have spoken about in our presentation. We are available to share the detailed form of our presentations for those ones who are interested in it. I thank you very much indeed. Thanks very much for the question that was raised to me. When we talk about active research or tracing of cases at the hospital level, is to improve surveillance so that we have a notification of the cases, because it's the pediatric section that was notified. Because we didn't have measles before, we had to inform other sections, pediatrics, animation services, to notify them that they need to be at a lookout. And in any case, they are supposed to take samples. That is why we had to sensitize our colleagues at the hospital level. Thanks very much. To end this session, I need one question to come from the floor for the colleague from Zambia. La Zombie?
Okay, je pense.
I think there is no question. Daliso. Daliso, isn't it?
You present measles, no? Okay. Why measles is a public health problem in your country?
All right, thank you so much for that question. I think first things first is that we acknowledge the fact that I think the community we're dealing with is a rural or remote community. And some of the challenges we've observed there is there are issues to do with long distances, okay, to the facilities. And also most of our communities observed that they are unable to follow their vaccination schedules. So I think above all, one of the contributing factors we are seeing in the community is that majority of our children haven't accessed the vaccines. They're not being vaccinated on time. Like I mentioned, if you saw in our discussion, I think we mentioned of vaccine failures that we say could be one of the contributing factor to the measles outbreak we are seeing. So I think due to the fact that the long distances and also caregivers don't follow the vaccination schedule for their children, we've seen that a lot of them are not vaccinated yet. Thank you.
Okay, thank you for your presentation and for your answer. And greetings for the presentation, for great presentation, I think. Many thanks for how we conclude this section. Thank you.
We may have
to switch over to poster presentation immediately.
Yeah.
Okay.
So, ladies and gentlemen, now we are going to proceed to the next section. The next section will be on oral poster presentations, and we hand over the floor to the next moderators, Dr. Raphael. Dr. Raphael, are you around? And Dr. Nicholas. Dr. Raphael and Dr. Nicholas. All right.
Not here. Not here. No, not here. You can hold out.
Is okay? Yes. Okay. Over to you, sir. Yeah. All right. Is it okay?
Go ahead. Let me.
Okay.
Let me see.
You see. Yeah.
So we have
Yanago.
Yanago.
Yeah. You put the Yanago.
Okay.
After Mohammed. Yanago. Yanago. Yanogo.
Okay.
Yanogo. Yanogo.
Okay.
Is it okay? Yanogo.
Then what's that? Factor associated? This is it. That is that's the person here.
Is okay?
Yeah. So the person should. When it comes in, we will educate a little.
Okay.
Because first of all, it is like this.
Okay.
So, and then
You can help us.
I can help.
Yeah.
I can help.
I take in
help.
French. Bonjour à tout le monde.
Good morning, everyone. We're going to speak in French. We're going to speak in French. Good afternoon, everyone. We are going to move.
Faire passer.
We have 11 presentations. And I would like to make sure that for this session, my name is Dr. Raphael Mbailao. My name is Raphael Mbailao. I'm from the Central African Republic. I'm a program director. And I would like to make sure that the assessors, Giroux and Dr. Masira, I hope that they're already in the room.
Come back. Okay. Okay. Okay.
I don't.
You come. Yes. So
You can come in.
No, let me see. Let me see where we are.
yeah, here. I want to start this one.
This one.
Good afternoon. So we've completed the first session. We'll give a 5-minute opportunity for those who would like to switch rooms and, but to go to different rooms. However, if you're scheduled to present in room 3, this is room 3. So 5 minutes to allow room changes, those who would like to switch rooms. However, presenters scheduled to present in room 3, you stay here and present here.
So now this is oral presentation. I mean, poster presentation.
Yeah, so the next session will be the poster presentation. The poster 1. Yeah, poster presentation, session 1.
I can begin. I wait for 5 minutes. Bonjour à tout le monde.
Hello, everyone. I do believe that after the 5 minutes, we are going to start and we're going to have 5 posters. And for this presentation, we're going to take 5 minutes for each presentation. So now I'm going to invite the first person, who is Guillaume Bianogo, to come for his presentation on the factors associated to the case of meningitis in Burkina Faso between 2021 and up to now. You have 5 minutes for your presentation.
I'm sick, but I can.
You know how to interact with this?
Yeah.
Okay. So you play right, then go to the next one. You play again right.
Okay.
Good.
Good afternoon, everybody. I'm Guillaume Bianogo from Burkina Faso. Okay.
Après, c'est...
After Guillaume, the second person is Ajara. Ajara Abubakar. Is he there? Ajara? Are you there? Yes, she's there. Just come. The third person is Adnan Mohammed. Mohammed, is he in the room? Mohammed, are you in the room? The third person is Ali Bori from Benin. Ali Bori from Benin. And then Tumani Sidibe. Sidibe.
It's okay. Yeah, une personne is not here. Yeah.
Blandi.
Ouais, yeah.
Or Musa.
Mohamed.
Adan Mohammed Al Hindi.
Yeah, he is not here.
Okay. Oh, this Zobure?
Yeah, Zubure is here.
Oh, okay.
Bon, vous avez 5 minutes. Hein?
Okay.
Et après, les autres.
Okay. Hello, everybody. I'm Guillaume Bianogo from Burkina Faso. You will excuse me in advance because my English speech is not very well. So I go to present to you my job on the meningitis. That the title is of factor associated with the meningitis, persistent or meningitis in Burkina Faso in from 2012 to 2021. So in introduction, we can say that meningitis is an inflammatory of the meninge. It causes approximately 1.2 million cases and a 1.2 million cases and 135 deaths each year worldwide. Meningococcus is the majority cause of meningitis in Africa. Okay. My language that I can communicate is French. I can try to speak in French.
So in Burkina Faso, meningitis, it's an epidemic. And I can tell you that it's something that happens a lot in the country. And among the prevention, we have mass vaccination, and we have persistence in terms of death in Burkina Faso caused by meningitis. Our objective is to determine through data tools the different factors that are associated to meningitis to reduce the mortality and morbidities that are linked to this disease. And for that, we came up with an analytic cross-cutting study, and the site were all the cases coming from Burkina Faso. And this is the map of Burkina Faso in its integrality. So our data was secondary data on the national surveillance in Burkina Faso. And for the analysis, we used Excel and Info and SAS to analyze. We got some proportion, we presented some graphs, and we adjusted them. And we also estimated everything that is linked to meningitis and all the factors like age, sex, vaccination, the vaccination status, and also place of residence. We considered also the various variables that are associated to 0.05% as threshold. As results, we found more than 24,000 cases of meningitis that were included in our studies for 10 years. And here we have the breakout of meningitis for the 10 years, and the year 2012 where we had more cases, and 2018, that's when we had less cases. And we had distribution in terms of meningitis 2012 to 2020 as far as the place of residence is concerned, and the rural area had more cases, 55% of the cases. And we have more than half of cases for people who have less than 5 years of age. For the distribution, as far as we can tell you that things linked to the lungs are the ones that were more affected, and also the male or the men were the people were the most affected by meningitis. And we also found that people who are less than 5 years old were really affected by meningitis, and this was statistically significant. And in the rural area, and also the issue of non-vaccination was associated to meningitis, and all this was statistically significant. To conclude, we could say that this study allowed us to describe the epidemiologic status in meningitis in Burkina Faso, and I can tell you that children who are less than 5 years old are the most affected. So that's why we are recommending to have a vaccination against these diseases for the children that are less than 5 years old, and to intensify vaccination and surveillance in Burkina Faso. In terms of recommendations, we have the same recommendations to increase the vaccination cover for the children who are less than 5 years old, and to have an active surveillance, especially in the rural area in Burkina Faso, so that we can detect more cases, and to have a reactive vaccination so that we can reduce this outbreak, and also to have a vaccination and to facilitate access to various tests in clinics, so that we can detect the cases of meningitis. So now I'm at the end of my presentation. Here we have our team that is in Burkina Faso, and we have presented our results during a workshop so that we could actually take the right decisions to get an active vaccination against meningitis, especially in the areas that are affected against this meningitis. Thank you very much. Thank you very much. You have taken 6 minutes for your presentation instead of 5.
This one?
Yes.
Okay. So, you know how to navigate? You know how to navigate? So, introduction,
Okay,
then you go out.
Okay, thank you.
Right.
Okay. La deuxième présentation.
The second presentation is going to be made by Ajara. It's still on the evaluation of a surveillance system against meningitis. You have 5 minutes for your presentation. Go ahead, please. Good afternoon, dear participants. I have the pleasure to present to you my work on the evaluation of surveillance systems against meningitis in the Niamey region in 2021. So as an introduction, we can say that meningitis, it's an inflammation of the meninge, and it's really difficult, and especially mortality that is very high, and we have many consequences, and the people who are most affected are the children. In 2019, we have more than 8.5 million cases with 63,000 deaths. And I can tell you that we have lethal, it's really lethal by 8.3%. And we have 24 countries of WHO and 15,000 cases, more than 15,000 cases. So this disease, it's in Africa, especially in the region that is nearby Niger. So I can tell you that in Niger, the biggest outbreak was in 2015, and we had about 8.5 million cases, and mortality rate, as far as the death is concerned, it was about 8.3%, and many regions have been affected. And I can tell you that meningitis is something that we need to declare, and it's mandatory in Niger. Despite all the progress, it's still a big issue in Niger, and that's why we needed to evaluate the surveillance system in the country. As a methodology, we used the CDC grid of 2021 so that we can see the various attributes like simplicity, acceptability, representation, sensitivity, and the quality of data. And the appreciation threshold was inferior or equal to 50%. From 50 to 75%, it's average, and superior or equal to 75%, that's very good. So this is a cross-cutting study that we led in Niamey in 2021. And the population constituted of all the actors that are involved in the meningitis surveillance at all the level, in the superior level until those peripheries, without forgetting the intermediary level. We also looked at the base of 2019 to 2021, we analyze all the data, and especially to assess the representation factor. We surveyed 26 health agents, and our results, this study enabled us to see that the system is useful. We have 100% of the people that have been surveyed that said that the system enables us to come up with prevention and also to have control measures. Out of the 26 that have been surveyed, we have 22 that responded to our questions. And in figure number 3, we have the different districts of the region, the 5 districts that had cases each year for these 3 years, and we have all the sex represented and all the age that are represented. So our system is really a representation of everything. So the other attributes, we have have simplicity, acceptability, sensitivity, and also the quality of data that have a score that is higher than 80%, and that is good. As far as discussions are concerned, we can say that our results are comparable to other studies that have taken place in Africa, like in Burkina Faso and in Mali. They assessed the surveillance system of meningitis. To conclude, we could say that our system is very useful, acceptable, simple, representative, and sensitive, and we have data of good quality. And that's why we are recommending that we need to take into account that system. So I can say that I'm at the end of my presentation. Thank you very much.
And then, right?
No.
What? This one?
Yes.
This one is not allowed? This one is not allowed? No. Oh, okay.
Benin.
Okay. This one? You have two. This one, right?
Yes.
So you know how to navigate when you go, huh?
Yes.
And
Yes.
okay, you can, okay.
Yes.
Okay. So you stop there. All right.
It's okay.
Yeah. So you can introduce yourself so that they see your title. Okay. So when you want to start, you click.
Okay. Je vais présenter. La troisième présentation.
The third presentation is about meningitis in Benin. So we're going to give you 5 minutes for the presentation, and please speak in the language that you are comfortable with. Thank you very much, Mr. Moderator. Dear participants, good afternoon. We have the pleasure to present to you the results of our study on the evaluation of surveillance system in meningitis in the district of Labori in Benin from 2017 to 2021. As an introduction, we would like to say that meningitis is actually an inflammation of meninge. In 2020, about thousands of cases were signaled in the region, in Niger, Benin, and other countries. And I can tell you that lethality of meningitis is about 14% since 2010. And I could tell you that this lethality was 17% in Benin. And in 2020, the Department of Labori, it's among the 12 districts that Benin has, had registered a lethality of 10.6%. Meningitis is under surveillance in this district of Benin through a surveillance system that is integrated, that needs to be assessed or evaluated regularly so that we can re-guide, so to speak, the interventions. And that system has never been assessed or evaluated, and that's why we are motivated with this study. What is the methodology that we used? Our study is a cross-cutting study. It's descriptive, and it was done in the Laribori district in Benin in 2022. And I can tell you that we followed the guide of CDC Atlanta, and it was what we used. The interviews were done with more than 56 agents of surveillance with the Kobo collector tool. And the data was analyzed with AP, and we had 80% of the objectives that we reached for each attribute. Here I can tell you that it's the map of the district of Laribori. The district of Laribori is in Benin, and Benin is actually country that is in the meningitis belt, and we have Niger on the northern side and Nigeria in the western part of that region. So what are the results that we got? We can say that 98.65% of the surveyors said that the definition of the cases was simple, and the notification was actually 45% of the people that have been surveyed. When we said that we did things at time, it was 99%, and we managed to complete everything by 100%. The data reflect the characteristics in terms of place, time, and the representation. I can tell you that the cases come from the 6 zones, and the system also enabled us to detect the outbreak of meningitis, and in 2019, especially in the Barikawa commune or zone, to be more specific. And I can tell you that here, what I'm projecting, those are some results that I would like to show you. And we should say that the first table shows the number of cases of meningitis that have been registered in some zones. And we have more cases in 2017 with 137 cases. And the smaller number of cases was in 2021. Now, as far as characteristics are concerned in terms of the distribution of cases of meningitis by age. The one that was most affected was people from 6 years old to 15 years old. For the advancement of cases, I can tell you that we had more cases in 2019, and we had a reduction of cases after we really got a reduction in 2021, reduction of cases, that is. To conclude, I would like to say that the surveillance system in Laribori was very useful. It was acceptable and representative. And I can tell you that in notification, and when we can file this notification form, can make this system more efficient. So here we have some references that we've used for our studies. Thank you very much for your kind attention. Now we would like to invite Sidibé to make his presentation that is about meningitis, the associated factors, and you have 5 minutes to finish that. Thank you very much, Mr. Moderator.
Nous sommes Dr. Sidibé Toumani.
This is Mali case. We have the pleasure to present to you the work. This is associated factors for meningitis. This is a case of 2017. Meningitis is a bacterial infection, which is a very big problem of public health, even if measures have been taken by different countries as a methodology. For Mali, We collected samples from administrative regions of Mali. This was received at the National Laboratory of Reference, Referral Laboratory at the national level. Here you have the different regions of Mali. Excel spreadsheets were used for our analysis. 5%, and this is the threshold guiding our study. As a result, ladies and gentlemen, 3,478 were registered during the period of study. 446 were confirmed. Before the introduction of meningococca in Mali, we recorded 1,545. 335 were confirmed. Rate of confirmation, 25%. 316 cases with a rate of confirmation of 16.48%. Ladies and gentlemen, results. Demographic, socio-demographic characteristics. Children of less than 1 year were most affected. The non-vaccinated were most affected, and people in rural areas were the most affected before and after the introduction of meningococca. Pulmonary streptococcus is the most frequent after the introduction. Contrarily, before introduction, meningococc was the element that explains meningitis in the sub-region. And the introduction of meningococc vaccine through routine vaccination in Mali, this meningococc is no longer of use now. The element responsible for meningitis, there is the type B, which is responsible. Associated factors, less than 1-year-olds were 3.87% affected when you compare this to other age groups. The 5-year-olds to 14-year-olds are associated, and those beyond 15 years are associated. The non-vaccinated are much more associated when you compare them with those ones who have been vaccinated. Those ones in the rural areas are associated with this bacterial meningitis. In conclusion, Mr. Chair, we could say that meningococca is no longer of use today because we have other remedies. We need to encourage much more coverage of vaccination so that we can eliminate meningitis from now to 2032. I thank you very much, Mr. Chair.
Après, nous allons inviter Moussa Amadou à faire sa présentation sur les investigations.
Mamadou, for your presentation on the investigation on meningitis as well. This is from Niger now.
Merci, Monsieur le Président.
Chair, thanks very much. Good afternoon. My name is Musa. I'm a doctor. I come from Niger. I have the pleasure to present to you investigation of meningitis in Busa district. This is a Tawa region in Niger. Bacterial meningitis remains a problem on health sector issue. It affects 1.2 million people in the world over. In sub-Saharan Africa, meningitis is very present in the meningitis belt. We find ourselves in this meningitis belt. The first outbreak is 2015, where we had 8,700 cases, fatalities 6.6 to 20%, and up to 30% of our health districts were affected. Busa talked about the cases from 14th week. In 2022, we identified these cases once samples were taken to the referral laboratory at the national level. The objective of this study is to see the scope of this problem and come up with the preventive and control measures. We carried out a study, descriptive study, in 2022. We used the definition of 2021 of Niger, and we applied a threshold of 2017 from WHO, and we looked at the records, and we carried out active search for cases. We had an investigation form. We did desk review, had interviews, and our data, PM4 and Excel software were used, and we calculated the rate of frequency, and we came up with a table to represent our results, graphs and texts to represent the findings of our study. As a result of our investigation, there is the index of this epidemic. As a boy of 6 years who didn't have a record of traveling, who had a fever 3rd April, and was taken to hospital and died the following day. So we talked about that they told us that there were 4 deaths in the village after the first death. And that's why the community was aware and started now calling upon help from the nearest health center. Description of the cases. In this graph, you are going to see the progress per week. The thresholds were surpassed the same week, and the peak was during the 2nd week. 44 cases of meningitis were notified. 95% came from the same region. The male were more affected. Median age 8, with extremes going from 2 to 15. The age group that was most affected is 5 to 14-year-olds. The majority of the cases, they didn't have a known record of vaccination. The 12 samples we tested, 4 came back positive, which is 33%. 55% of type A and type B, 54%. Mortality during this pandemic is at 20%. This mortality is much more pronounced in the 5 to 14-year-olds. The first week, 50% of the deaths were notified. Actions that we carried out, we did vaccination that helps us to reach 87% of children from 1-year-olds to 14-year-olds. We carried out activities of communication of risks. We involved the community, and this helped us to sensitize the community so that they can fight with us against meningitis and go to use health services at the best opportunity. Discussion. So males were more affected. This predominance has been cited in other works, in other studies. Age group 5 to 14-year-olds, we understand that this age group is the most affected. This is the same finding in other studies. Mortality, 20% in our study. 87% of the death, this was captured during the first week. So if we didn't put in place control measures, taking care of people and fighting together was most important. In conclusion, this meningitis of Group B, this was responsible for the pandemic in this district of Busa. So we have vaccines rather, but this has not been done for Group C. So we recommend that there is introduction of the tetravalent vaccine to vaccinate the populations when we carry out routine vaccination campaigns. Some photos during our investigation. Here is a session of sensitization of the community, active research or looking for cases. Here, it's an health center where we went on the ground to sensitize those ones who are there. I thank you.
Question. Are we going to take it or we take it at the end? Yeah. We can do everything and we take it at the end? Or do we? Is no plus. Look at this one. Yeah. Then before we continue. Yeah. Okay. Bon. Monsieur.
Ladies and gentlemen, we have followed 5 presentations dealing with meningitis. The first presentation, we talked about the associated factors. This is the case of Burkina Faso. The second is assessment of surveillance systems in Niamey. Third speaker was absent. We went to the fourth, assessment of surveillance systems and associated factors to acute meningitis before the introduction of vaccine for type A. So those ones were present here. We are going to allow ourselves to have a short session of questions for the 5 speakers because we are remaining with the 6 presentations. The experts who are very far because the posters are not very visible, you need to come closer here so that you are able to see better what is being presented on the screens. So the session of questions is open. During the time of question, you introduce yourself and then you say to who you are addressing your question. I'm going to start there. You have the floor. Do we have a microphone over there? Be precise. We have just 5 minutes. If you take 30 seconds, that will be ideal. For the question, kindly say who you are addressing your question to. The different speakers, thanks very much for the quality of your presentations. My question is addressed to my brother from Benin for some aspect that really caught my ear. In the introduction, in the mortality caused by meningitis, and this is 17%, if I am clear, for Benin. But for the other African countries, they are saying that it's about 10 to 14% mortality rate. My question is to know this very high mortality in Benin. What explains it? Because in your studies, the representation, it's clear that meningitis, 98%, those ones who are interviewed were of the opinion that the definition is clear and clear enough. Diseases like meningitis, the first criteria which brings about mortality is the lack of information on the disease. So for this figure, I'd like really to have more clarification. Another criteria that can raise the mortality is a lot of time that is taken before anything is taken as an action because they don't know the disease. Thanks very much to clarify that. Thanks very much for this question, which is very clear. Introduce yourself. Thanks very much. This is Dr. Traore, resident advisor. Niger. I'm coming back to the mortality. This very high mortality rate, have you assessed the time this is declared and when you intervene? Because to vaccinate and there is a reaction, kindly come back and explain to us the reasons that we need to watch out on to avoid such a big mortality. You were clear and precise enough. Thanks very much. Microphone, my left.
My name is Aisha Abba from Nigeria. Well done to the presenters. So my question is directed at the NEAMI presenter. So you mentioned that you interviewed 22 people from the surveillance system while carrying out your evaluation. So I would like to know if your evaluation was only based on the response from the surveillance officers, or if you used other avenues or methods, objective avenues or methods to support the responses you got from the surveillance officers. Thank you.
Okay, merci encore une fois.
Once again, thanks very much for this question. I think that in the room, we don't see any raised hands to ask for the floor. We are going to give the floor or the microphone. Could you clarify your question better, the last speaker?
Okay, so you mentioned that during your surveillance system evaluation, you were able to, out of 26 people, you were able to interview 22 surveillance officers. So I was asking if the whole evaluation was based on the responses from those surveillance officers, or if you use other objective methods or avenues to support the responses you got from the surveillance officers. So I don't know if it's clear or no.
Je pense que c'est bon. Vous avez bien compris maintenant.
I've well understood now. We are going to give the microphone to the speakers to be able to give responses to the questions that have been asked. Are you hearing me? We thank the participant for their question. I interviewed 26 health providers, and there were 22 who answered. They are responsible for surveillance from the national level to the grassroots. There is a microphone on. Thank you. 2019-2021, we used other tools of surveillance, such as the notification form. So we didn't really depend on the answers from the surveillance officers. We used other tools. I thank all the participants for the attention that you have manifested to our presentation. For the question that has been asked after our presentations, as we said, in the desk review, we realized that in Africa, we have 5 to 14% mortality rates. But we came up with a mortality rate of 17%. This mortality rate was observed in 2019, between 2018-2019, excuse me. During the period, we had a pandemic. The cases that we received in this region or district, they had atypical symptoms, and there were a lot of deaths in the community. And the symptoms presented by these patients, they are symptoms that are not really traditionally or in a traditional way considered as meningitis symptoms. Abdominal pains. After a day, the person is gone, is dead. The community realized that there were a lot of deaths, and that is why they had to seek help at the health centers. Afterwards, we carried out investigation. Even the investigation team on the ground were not able to do the diagnostics clearly because the signs presented, the symptoms presented by the patients, there was no symptom linked to meningitis. The fever that we know, the nape problems, that is why it took long to know that this is meningitis. This explains, in 2018, that's why we have that big mortality rate. But I think that the question likes you to be clear. the not knowing of this disease, the time taken, long time taken to fight back, doesn't that represent the high mortality? In our study, when we talk our health centers, case definitions was a simple task, and this case definition was respected because during the investigation we had to do a desk review using the health records. At the health centers, we had not really realized that there was late or delays to take care of these people. This was maybe at the community level. Thanks very much. My brother, thanks very much. My brother from Mali, thanks very much for the question that you addressed to me on the reactivity of our health systems, a real problem. I'd like to start to answer this question saying that the first cases of meningitis were recorded in a village that didn't have an health center. This was the first problem. And at the operational level, the system was very reactive because the first case was noted on the 14th week rather. The 14th week, samples had been taken to the National Referral Laboratory. Week 15th, there was confirmation at the laboratory. 16th week, we were on the ground to carry out investigations and start to fighting back. Another problem is the germ, which is involved. What is the profile of the suspect element causing all this before you choose the right vaccine, before you can really repost in time? Here we go. This is the end of the first 5 presentations. We need now to thank the speakers, ask them kindly to leave the podium as we receive the next 6. We can give them a round of applause.
Blandine.
Blandine. Carlota Martino. Carlota Martino. Siswe.
Here you go.
Thank you.
So as we
En attendant, les orateurs gagner la tribune.
Would like you to evaluate the day. I realize that some people are leaving, but in every room there are QR codes on the walls. So as you pass by, you can scan that code, and then it will take you to the evaluation. You evaluation the aspect of today, and give us feedback to better prepare during the week, but as well as subsequent conferences. So they are on the walls.
Saeed? Do we have Saeed here? Oh, okay.
Saeed.
There should be 6. There should be 6. Who is missing? Mansour, Abubakar Mansour. Okay, so call this person to come.
Abubakar Mansour and
Oh.
Kumalu.
Okay.
Kumalu.
He's here.
Kumalu.
He's here.
Kumalu.
Since was here. So there should be 6. Yeah, they are complete. Come.
You can,
how did you go there?
You can begin.
Come. Oh, F11. Oh, full screen.
And then the arrow to the right, There is those arrows.
No, this one.
This one. Yeah, correct.
Okay,
Nice. Good.
so how do they check it? Oh, okay. Okay.
Is okay?
Yeah. So
you can begin?
Yeah, they can begin. Blandin.
Yeah. Blandin is here. Okay. Bon, nous allons inviter Blandine.
We are going to invite Blandine to make her presentation in 5 minutes. And her presentation will be on the evaluation of a surveillance system of meningitis in Selembao in 2022.
Okay, merci.
Thank you very much. Good afternoon, everyone. My name is Blandine Kisangani. I am a medical doctor. I'm the chair of FETP of the DRC. We have the pleasure to present to you our work that is about the evaluation of surveillance systems of meningitis in the health district of Selembao in 2022 in DRC. The first thing that you need to know is that in 2022, DRC had about 3,000 cases of meningitis and 189 deaths. And the lethality rate was about 4.9%. And for surveillance, I can tell you that it was done in Selembao district, but the performance was not really good. And that's why we are doing an evaluation study for the surveillance system.
Pour atteindre notre objectif.
To achieve our objective, we undertook a cross-cutting study that was descriptive in the Selembao district and to do a surveillance of meningitis, and that is actually the map of Selembao where we undertook our study.
Et les données ont été enregistrées.
The data was recorded when we did some interviews, observations, so that we could evaluate the organizations and the operations and the various attributes of the surveillance systems, like simplicity, usefulness, the acceptability, the predictive value, and representation and reactivity of the surveillance system. And we also we've also come up with some analysis, and those are the results now that I'm going to present. 39% of the focal points of the surveillance that were interviewed, and when they described the cases of meningitis, and in terms of equipment, there was actually some rupture of the equipment, and the material was not working very well, and we had some issues. And we also observed that the system was not really useful. It was simple, acceptable, and the cover was very weak, and we think that it could be due to the lack of good internet connection. And the cases, majority of the cases was in three zones. The quality of the work was actually done, and it was good, and you can see the table that is in front of you. And we do believe that the surveillance system of meningitis in Selembao in Kinshasa did not really have a good performance, and that's why we need to strengthen, to do some capacity building of the members of staff that are in charge of the surveillance in that district of Selembao, and to have an integrated surveillance. I would like to thank you for your kind attention.
Applaudis. Merci. Vous avez fait.
Thank you very much. You've taken about 4 minutes. Now I'm going to invite the second person.
Mansour.
Mariama, oui. Trompé de Ménétique. C'est au Niger.
Oh, you are Mansour, right? Sorry. So you know how to navigate? So, okay. Right?
C'est pas ça. District sanitaire de Bouza, moi c'est jeune comme ça.
So what happened? This is it?
Ça c'est pas pour moi.
This one?
C'est pas pour moi. C'est jeune comme ça.
Parlez-vous anglais?
Non.
No, vous parlez anglais. So this is
C'est pas-
mal or bien? Mal?
Ça c'est mal.
C'est mal? So it's not that one.
Okay.
Manzo.
Mariam,
This one?
Yes.
So you know how to navigate?
Comment on fait?
Boom, boom,
Ah,
boom.
attends, je vais.
Bien.
Ok, merci. Donc, merci, Monsieur le Président.
Thank you very much, Mr. Chair. It's a great pleasure for me to present my work for this CSE2 in the region in Niger. Meningitis is actually an inflammation of meninge that is actually a big problem, health public issue, and we have a high level of mortality and morbidity, especially for the young children. We have many things that are in the fundamental cause of this disease. Niger is actually in the African belt of meningitis. So each year, this country is actually facing outbreaks. We have 3 zones where we are really affected: Penta, PCV. 13. And for the first region, we have 11,000 cases that have been confirmed, and we have 94 cases actually linked to meningitis. For Margaria district, 278 cases, and that were actually registered in 2023. And for CSE of Gaza, we have about 8 cases, suspect cases, that have been notified. And that's why we came up with this investigation, so that we could look for other cases And we are trying to implement prevention measures against these various cases. So we came up with cross-cutting and descriptive studies. And to do data collection, we reviewed the various registers so that to see that if the suspected cases were notified, and also to see if we have suspected cases that were not notified. And then we had some interviews with the health agents and active research within the community. We also had some testing that was sent into the labs, and the data that were collected were actually analyzed with Excel 2019 software. So as far as the results are concerned, we had 2 index cases, 2 brothers that came to the CSE to be consulted in January. And from January to May 2023, 34 suspected cases were registered in 3 households. In Jelgawasa, where we had that's the place that is the most affected with about 44%. Now the median age is 11 years with an interval of 3 years, and 5 years and plus it's 70%, and for the 34 cases, none of them were vaccinated. So we have received 3 results. One was positive to meningitis. Despite the fact that the investigation was early, but there was also various actions that were taken, but the outbreaks actually expanded in many places, and lethality was actually reduced. For the 34 cases that I've mentioned, none of them were vaccinated, despite the fact the CSI was actually something that was very significant, and it really affected many regions. So in conclusion, I can tell you that we have Neisseria meningitidis. That is the gene that is actually responsible for this outbreak. There are many actions for public health that were undertaken, isolations, and also taking care of these cases, the briefing of the health agent as far as the definition of the cases are concerned, and also our awareness campaigns towards the community so that they can go to get this treatment. Our recommendation is actually to introduce the vaccine to this disease. So I would like to thank you and to thank all these organizations that have helped us. And you can see their logos. Now I'm at the end of the presentation. Thank you very much.
This one. No, it's the other one. Preview. No, this one. Preview. Mode preview. Merci.
Thank you very much, Mr. Moderator. Good afternoon, everyone. we have the pleasure to present to you the results of our work on the epidemiology profile in meningitis in Benin from the 1st of January 2017 to the 31st December 2021. I would like to say that meningitis is actually an inflammation of meninge that is actually a priority disease of public health because of this epidemiology potential. And I can tell you that it comes in part of Africa that is called the meningitis belt. And I can tell you that the lethality of it's about 7 to 14% since 2017 and 17% in Benin in 2020. The data analysis is done to describe the epidemiology profile in the district of Larimori. And as far as the methodology is concerned, I can tell you that we came up with a cross-cutting study in the district of Laribori in Benin, and it was about 425 cases that were registered, and epidemiology surveillance that was integrated for the response to diseases in 2017 to 2021. The data were analyzed through a certain tool for the statistics, and all the frequencies were calculated. I can tell you that the district of Laribori is one of the 12 districts that Benin has, and Benin was actually in the meningitis, in the countries of the meningitis belt. And that district is bordered in the west by Nigeria and north by Niger. What are the results that we managed to get? I can tell you that the data were extracted, and before analyzing this data with APA Info, which is a software, we registered about 425 cases, and we have an incidence of 8.84%, and lethality was about 8.25% with an incidence that was very weak, with 2.39% for 1,000 per inhabitant. In 2017, we had the strongest lethality that was 14.15%. The median age was 9 years old with an interval of 0 to 45. And I can tell you the sex ratio, it was 1.28. And age, it was 5 to 9 years old were more affected, and 14.6% of cases were confirmed. And the young people that were affected were affected by Neisseria meningitis C, and 46% with pneumonia, 33% of Neisseria meningitis X for 15%. And the zone that had the most cases were Malambile with 46.16% for 1,000 inhabitants. That was in 2017, followed by Kambi with 11%. And the incidence that was the weakest was in 2021 in Barikwara zone, 6 zones of the district with an incidence of 0.86% for 1,000 inhabitants. In conclusion, I can tell you that meningitis is still in the Laribori district, especially for the children from 5 to 9 years old, and vaccination with the early care is very important. And we have some references that we've used to achieve our objective, and we are at the end of our presentation. Thank you very much for your kind attention.
You can navigate right.
Yes.
Just click there.
Okay.
Then okay, then also you can, if you have to scroll down, maybe like this one, you can scroll down. Okay?
Yes.
Okay, thank you. All right.
Good afternoon, everyone. My name is Martinosa from Guinea-Bissau, Ghana FTP residence. I'm presenting measles outbreak investigation in Guinea-Bissau in Portuguese. Sarampo e ngalbu di eliminação na Guiné-Bissau.
Measles, it's a serious problem in Guinea-Bissau. In 2022, on the 17th of March, we reported the measles situation in Guinea-Bissau. The objective was to understand the pandemic of the sarampo and to identify the cases by time, people, and to determine the cause of the death in that area. The study was done in a community base. We identified the families who lost their families, and we looked and we identified for cases in the community using the definition case on any person who is suspected to have any fever or any type of disease in that area was to be studied and monitored. So the cases were cases that would get clinical and laboratory cases regarding to the epidemiologic situation, and we also confirm the cases through suspicions and through report by the laboratory. So the results of mortality were made using Microsoft Excel to study to analyze the data. Well, out of the 46 cases identified, 13 were results of death, and all these deaths were by women, and 66.7% of cases took place in the district of Dilegi, and 33 cases, or better, deaths took place in the village of Busuri. So all the suspected cases, in the 46 cases suspected, 8 only received the measles vaccination through our investigation. And this table displays on how the cases were collected according to the gender, whereby males was represented with the highest percentage in all identified cases, and that we collected all the samples. This table displays the risk possibility of measles in that area according to the districts, whereby Tabanka district presented a 4.8%, which was the highest case in that area comparing to the many other districts. Well, this one shows the level whereby the cases were identified from the 8th week up to the 17th week, and there was a decrease on the 17th week. So this map shows the distribution of the cases according to each district and according to each health center. To conclude, and the recommendations, the investigation of the measles was confirmed as a pandemic in that area, and we recommended the health centers to become more strong and to be more surveillance in each community. And we also recommended that all health technicians should vaccinate all kids according to all the children that visited the centers. And we also came to the conclusion that all kids that we identified on the 48 cases, we noticed that all these children were vaccinated, and this gave us a result of 33% of coverage. And we also recommended the Ministry of Health to be able to train their staff for them to be able to respond to any emergency or any outbreak. Well, the action that we identified or intensified, we identified some cases in the communities, and we did a campaign regarding measles, and we sensitized the technicians in all the technicians that are involved in the vaccination of measles, and this is how we train all the health staff. Thank you very much.
Let me just see, like this, I come here, and I click on the pictures. Yeah, I can scroll down. Thank you. Good afternoon, all. I'm Akimbo Ali Said Olalikon from Nigeria. I'm here today to present measles in Ogun State, a 5-year review of case-based surveillance data from 2016 to 2020. As has been said severally, measles is a common viral disease, and it's very contagious. And many states in Nigeria have reported several measles outbreaks over the years, and outbreak is still being reported over and over again. In 2020 alone, in Nigeria reported about 15,099 suspected cases of measles in 23 of the 774 local governments in Nigeria, and 32 of the 37 states, 36 plus 1, including the Federal Capital Territory. Now, this said, measles in Nigeria is a big problem, which we continue to see over and over again, day in, day out. We, in this study, we describe the trend of measles cases in Ogun State, one of the 36 states in Nigeria, from 2016 to 2020. And the purpose is to guide future intervention. Our method. This study is basically a secondary data analysis, and our primary source of data is the line list of the epidemiology unit of Ogun State Ministry of Health. We cleaned the data, we summarized using Excel, and we analyzed using EpiInfo version 7. The key results and the key findings from our study. We observed that between the period of study, the 5-year study that we reviewed, we observed that there's a total of 2,078 measles cases reported in Ogun State. That is between 2016 and 2020. We also observed, as regards gender distribution, that there's no difference in gender distribution. The cases are almost equal between male and female. And most of the cases between 2016 and 2020 reported and had evidence to have had at least one dose of measles vaccine. And over the years, that's the trend between 98%, 99%, 73%, and 98% respectively. Now, looking at the age distribution of measles cases in Ogun State, we classify them into less than 5 because that is a priority age group, and the other age group is greater than 5. That is our basis of classification. Now, the blue chart here represents the people greater than age 5, while the orange chart represents people less than 5 years. We can see that in 2016, we have more under 5 who reported measles cases. As we go to 2017, we have similar picture. But as we get to 2018, we observe that adults or people greater than age 5 reported more measles cases as compared to people less than 5. And that trend continued till year 2020. Now, we look at the trend in terms of number of cases counts of suspected measles cases across the 5 years in Ogun State. We observe that there's a peak in 2017, and this is basically due to increase in surveillance system around that time. The state government strengthened the surveillance system, employed more people, more training, and that could account for this increase we noticed in 2017. Also, looking at the 20 local governments in the states, we arrange the number of cases, of measles cases, according to prevalence. And we observed that Abeokuta South, which happened to be the state capital, and where there's Federal Medical Center and other tertiary center, happened to report most of the cases of measles. In conclusion, we observed that measles cases in Ogun State declined from 2016, but it is still a major concern because we are still reporting a significant number of cases across the state. And we observed that age group greater than 5 are becoming more vulnerable to measles infection as compared to age group less than 5. And we also observed that single dose of measles vaccination may not be sufficient, based on these findings we observe here, may not be sufficient to provide lifelong immunity. But this study has some limitation, and one of the limitations of this study is that we only accounted for measles cases that were reported at the health facility, because those are the cases that were documented. Cases treated in the community were not documented, and we do not have data for that to analyze. Part of our recommendation for the state was for the states to intensify routine immunization and supplementary immunization, specifically supplementary immunization, because of the age group greater than 5 that we find that are more affected recently. And this recommendation has been implemented by the state. Last year, the state held a supplementary immunization activity for measles to immunize all age group against measles. I acknowledge Ogun State Ministry of Health for the contribution and data provided, AFENET and CDC. This is part of what I've showed earlier, just for calling our attention. The trend we saw over the years. We can see the trend here that the peak of the cases is the same from 2017 to 2020, which fall between January and February, and that fall between the harmattan season and dry season in Nigeria. Between February and March happen to be the dry season, and that is where we find that. So our conclusions and our recommendations has been implemented by the state, and thank you very much.
You can navigate, right?
Yes, I think so.
Good afternoon, everyone. I'm going to
Boa tarde a todos.
investigation of measles outbreak in Chief Albert Lutul Subdistrict in Mpumalanga Province, South Africa, March 2023. So measles is a vaccine preventable highly contagious disease, which is a disease of public health significance. So in South Africa, we have sporadic cases of measles that were reported throughout 2022. So 8 of our provinces out of 9 declared measles outbreak. So 86% are reported among those aged under 14 years. So we had our index case suspected on the 8th of November, which the results came back, and the rapid response team initiated 22 November 2022. So we wanted to assess the magnitude of measles outbreak, to implement the preventative and control measures, and to make recommendations. So we did a descriptive cross-sectional study with the cases were coming from Mpumalanga, South Africa, under Hertzbande District, Chief Albert Lutul Sub-District. So suspected case, it's any person with fever and maculopapular rash with the 3 Cs in Chief Albert Lutuli from 8 November 2022, probably any case that was epidemiologically linked with rash development occurring 7 to 21 days apart from a confirmed case, and then a confirmed case, suspected case with laboratory confirmation. So we conducted in-person interviews at schools and households, and then we reviewed the immunization cards. So blood samples were collected, and tables and graphs used to analyze line list data using Microsoft Excel and then the incident rate was calculated per 100,000 population, and then the cases were mapped. So week 45, that's where we had our index case, and then the rapid response team started to do case search or case finding, where cases were then found, and then there were cases that were suspected, and then the results came back positive. That's how you see the graph of the epidemic cave goes. So the median age was 8 years, and the IQR 4 to 12 years, and then the majority of the cases were 31% aged 5 to 9 years, and then 66% of the cases were females, and then the incidence rate for our cases was 17.72 per 100 population. So unvaccinated and unknown cases were most the ones that dominated the group of the positive cases that we had. So our cases, they were epidemiologically linked, most of them. This is the index case with 6 cases linked to them, and then another cases that were linked on another a place where the cases, they were also linked to each other. In conclusion, the existence of measles outbreak was confirmed, and the sub-district had suboptimal vaccination coverage. So active case search, investigation, and line listing of cases was done, and then we conducted a local vaccination campaign targeting children aged 6 months to 15 years, and then we raised the community awareness via community healthcare workers and local radio stations. So our recommendation, we strengthen routine immunization services for measles, and then we continued with promotion of awareness in the community by health education. Thank you.
Okay. Mesdames et messieurs, nous sommes...
Ladies and gentlemen, this is the end of these presentations, 6 in total. The first 3 talking about meningitis, and the last 3 talking about measles. So these are diseases that can be prevented through vaccines. We have seen that there is a problem of new outbreaks of these diseases, and this informs the studies. You followed with me, and we are going to work the same way we worked previously. We take questions. We could start from there to this. Previously, we started to my right, now to my left. Over to you. Somebody to give him the microphone. Kindly, you be precise.
Godwin Apan, so I'm directing my question to the presenter from Nigeria. From what is projected, more cases were recorded among cases, those that were greater than 5 years. But we saw results for those that were less than 5 years, and also those that were greater than 5 years. So but what happened to those that were equal to 5 years? So, where do they belong to? Are they with those greater than 5 years, or with those that were less than 5 years? Yes, that's just what I want to know. That's it. Thank you.
Passez le micro.
Kindly give the mic over there. First here.
AFENET. I had a question, for Hajar, sorry, am I looking right? Blondine and Abu Bakr. Given that your countries are in the meningitis belt, what prevents the health authorities? What is the obstacle, and how can it be addressed of vaccination campaigns to protect the vulnerable population? Thank you.
So, okay. My name is Kuliso Rabwari from South Africa FETP. My question goes to presenter number 4. I think it's Carlotta. So in your recommendation, you indicated, you recommended training of healthcare workers. But in your findings, I wanted to check if you did any, survey to check the training status of the healthcare workers given the recommendation that you made to say you want to, train healthcare workers. Thanks.
Thank you very much. My question goes to Mr. Manzo. I'm sorry if I've given you the wrong title. Why did you present absolute numbers for the graph and not attack rates? I don't think absolute numbers say anything big. Maybe you had a reason. Why not attack rates for the number of measles cases? And then in your conclusion, you said after the recommendations, the ministry vaccinated all age groups. What did all age groups mean? Did that mean below 5, above 5, 60, 40? That was not clear. Thank you.
Ici. Allez-y.
Ouais, Joseph Ochudi.
Joseph Ochudi, Côte d'Ivoire.
Presentation. I saw that many about the vaccination. You add a lot of unknown status. What do you recommend about it? Thank you.
Ok, on finit avec ces deux rangées.
Question is from my Nigeria presenter. From the graph, the peak of the graph was in 2017 was high, and you said there were interventions taken by the government. So I want to know if this intervention was a continuous intervention for throughout the years, while the cases were dropping. And also in your conclusion, you did not state that there should intensify those interventions to at least find out more cases. Thank you all.
Ouais. La dernière main.
The last hand, please.
Presenters, my name is Florence Mugo from Kenya. I have a question to our Nigerian colleague. You presented in your data methods how you analyzed the data from 2015, but in your results, you presented to us 2016 data. So I don't know whether it's a typo, maybe you can demystify that. Then on your results, again, you reported age group of less than 5 and above 5 years. So my question is, up to what age did you analyze the data? Because it's like forever, so you need to tell us. Was it up to 70 years? Was it from 5 years to 70? Yeah, something like that. You need to clarify that. Thank you.
Bon, moi...
Dr. Abdullahi from Niger. My question goes to the colleague from DRC. I'd like to know how you identified, how you defined rather the quality of your data. She said that the quality of data is good, given the predictive value with a good percentage. What are your definitions for the two terminologies in your study? Thanks very much for these pertinent questions. Now we're going to allow the speakers to give responses, and we are going to go by order of the turns you took to present. Who went first, who went last? Is it by question or is it by order of presentation? Maybe we look to the questions first. Thanks very much for your observations. Thanks very much for your questions. For the obstacles that could stop us from carrying out vaccination campaigns, I think of more of financial obstacles because the limited resources at our disposal, it's not enough. It can be taken to other diseases maybe. So this is a question of financial problems or constraints. Merci. Obrigado.
The question that you presented regarding the recommendations, I can say yes. If we to look at it well, we've been doing something because during the investigations we try to talk to the health technicians to see if they know how to test, if they understand what measles is, because many people don't know the definition of measles. And that's where now we intervene during our investigations, during our assessments, and we try to teach them how to suspect that this person has measles and how to identify measles cases. And during our interventions, we also noticed that there were some mistakes on identifying measles cases, and that's why in the investigation we always push the public ministry to be able to train their health technicians for them to be able to identify the measles cases so that they are well trained and they're able to respond to this type of cases. Thank you very much.
Greetings all. We haven't really had questions to us, so we take the mic to the next person.
Answering the question of unknown status and unvaccinated. So because of limited time, we didn't include maybe more of information because we were going to be above time. So all those that were eligible for vaccination or to be catch up with the vaccination, so they were followed up to be catched up with the 2 doses of measles vaccination, which is those that they are less than 5 years and less. And then those that they were above, they were given only a booster dose because they are no longer qualifying to be given all the doses that they missed when they were supposed to get. So all those cases that we had, they were followed up and they were given all the necessary doses that they qualified for. Thank you.
Thank you for the questions and comments. Your observations were well noted. For the age group greater than 5 and less than 5, asking about where those 5 years old belong. They are actually 5 years and above, while the less than 5 is strictly less than 5. Anybody who is 5 years on dot is fall with the category of 5 years and above. Concerning the intervention is still continuous, as training of surveillance staff is still ongoing every day, almost every time. And even myself, as the acting state epidemiologist, I still attended some form of training during the week. So that is still part of strengthening the system. So the intervention is ongoing, to clarify that. Concerning the peak in 2017, yes, the intervention started 2016, and the result is what we saw in 2017, and which I've said earlier, the intervention has continued. Concerning age groups and what actually the intervention was, for those less than 5, second dose of measles have been introduced into the routine immunization schedule to cater for those categories. The supplementary immunization activity done was to cater for those who are not eligible for the routine measles second dose. So I think that's all the questions. Thank you.
Donc, merci beaucoup. Il y avait pas de...
There was no question that was addressed to me. I thank you.
Est-ce que toutes les questions...
Were all questions answered too? There are questions that don't have responses. So I think all is good. Time is not on our side. The other questions can continue in the corridors. As well as the quality of the presentations, the responses that were not given here in plenary can continue in corridors because we have not really enough time. We don't have enough time. I thank the speakers. We give them a round of applause.
At this point, we'll break for a tea break. Remember, you still have one more session. Sorry, one more session to go. So kindly go for tea. In the tea area, we'll use 15 minutes.
To everything, turn, turn, turn. There is a season, turn. To everything, turn, turn.
a model of a virus.
Ooh, the room is.
Are we back now?
Yeah, I'm calling to the house to order. Are you one of the?
No, I'm controlling the.
Oh, you are room controller.
Controlling the presentation. This thing is.
I kindly request for us to move to the front seats so that we pay attention to our presenters. We are about to start with the last session of a day. Not an easy one though, starting after 6. Had been a long day.
You may have to confirm the presenters.
Mm.
Once they are here, we can start.
Yeah.
We have 8 of them. And then the last one might not be here. If he's not here, we will play his video. Yeah, he sent video. I don't think he will be there to take questions because I'm not connecting any online. So.
Okay.
Right. But those the presentations are all here.
Yeah, I think it's time we start, but I don't know if we... this session, we should be starting in the next 3 minutes. But before so, I just want to confirm if we have all the presenters. Supposed to have 8 presenters for this session. Is it 8? 1, 2, 3. My name is Emmy Els Ndevaitela from Namibia. I'll be moderating this session. I welcome you all to the second oral concurrent session themed maternal reproductive and child health and HIV/AIDS, tuberculosis and other opportunistic infections. I'll have two evaluators. Just want to confirm if they are in the room. Patrick and Pire, are you here? This is Patrick. Eh? You are a presenter? I was just seeking for my evaluators. Patrick is here. Where is Pire? Or Pire? I don't know if I'm pronouncing it. How do I say that? And Pire. Where is Pire? Where is he? He's coming. Okay. Then my presenter is ready to come on the podium. So I'll want the 4 first presenters to join me on the podium. The first 4 sessions, which will be presented subsequently before we take the questions and answers. We will have geographical distribution and economic factors associated with rapid tests for recent HIV infection in Uganda by Immaculate. This is you, right? So let's start here. The first one should take the first seat. Veronica Follow, who will be presenting facilitators and barriers to tuberculosis case notification among private health facilities in Kampala, capital city, Uganda. The next one is Emily, right? Who will be presenting on factors associated with the use of directly observed treatment among tuberculosis patients in Mombasa County. Then we have Vincent, who will be presenting on C-reactive protein levels in patients initiating dolutegravir-based antiretroviral regimen in Ghana. Yes. While we are waiting for the second evaluator to be in the room, I just want to confirm that the other 4 presenters are in the house because they will soon take the podium once we finish the questions and answers for the first set. So we'll have Kizito. Are you in the room? Or maybe they will be coming closer to their time, but it will be good to know that they are all around. We have Olubani, who will be presenting on rifampicin resistance and determinants in TB patients attending clinic in Abeokuta. Is he here? Oh, is he? You are the one? Oh, thank you. I think I missed, I jumped to the first one, analysis of childhood TB notification by Jonathan. Is Jonathan here? Thank you. I'm informed that Hamad might not be here, so that will make our session shorter, probably, if we miss one. So, again, I kindly request our audience to come closer because the presenters want to be great to feel your presence being nearby instead of presenting to empty chairs there. Let's move closer. Is this Bill? My evaluators, are you both there? Patrick? Is this Bill? Okay. Okay. My presenter, please take note that the 2 evaluators are in the room. So they will be looking straight to you to evaluate how you will be presenting. So this is oral session, so each presentation is 10 minutes. Since we'll be doing 4 sets following each other, to save time, I wouldn't want to come between the sessions, the presentations. I would request the presenters immediately once the first one finish, then the next one take the podium so that we save time. Then I'll just stand after all 4 have presented to invite the audience to comment or to ask their questions to the presenters. I hope by that doing, we'll save some time. Then we'll have about 20 minutes of questions and answer session. So without further ado, we will start now with the first presentation, which will be presented by Immaculate. Over to you. Thank you.
Thank you. Good evening, ladies and gentlemen. My name is Brenda Simbwa, an advanced field epidemiology fellow with the Uganda Public Health Fellowship Program. I'll be presenting a study on the patterns and distribution of RTRI recent HIV infections in Uganda
2019 to 2021 on behalf of Immaculate at Haire. Recent HIV infections are considered those that were acquired in the past 12 months. In 2019, HIV recency testing was integrated in the routine HIV testing services in Uganda. By September 2021, the coverage of HIV recency testing was over 600 sites, but only 325 were reporting HIV recency testing. Here, I present the recent infection testing algorithm involving 2 steps. The first step involves conducting a point of care screening test for the newly diagnosed persons with HIV, 15 years of age and older. Consenting persons are given the AFENET rapid test, which is a dipstick test that can indicate recent infections. This is called rapid testing for HIV recent infection, or RT-RI. If the HIV infection is suggested by that rapid test, in the second test, the viral load can be tested to confirm whether or not the infection is recent. If viral load is at least 1,000 copies per mil, this is strongly indicative of recent infection, whereas viral load of less than 1,000 copies per mil is suggestive of long-term infection. However, when our study was done, the viral load testing data was not available. Okay, so we strive to control the HIV epidemic. There's need to understand how recently a newly detected case was infected. Finding clusters of recent infections will contribute to the identification of hotspots and guide improvement and implementation of case-finding strategies, including risk-based HIV testing methods. We therefore conducted this study to evaluate the relationship between socioeconomic status and recent infections during November 2019 to December 2021. We also wanted to determine the geographical units with high proportions of RT-RI recent infections in regions implementing recency testing. In our methods, we used program surveillance data for newly identified HIV cases tested by rapid test for recent HIV infection during November 2019 to October 2021 from 112 districts carrying out recency testing. Wealth quantiles were derived from aggregated household level data from the 2019 Malaria Indicator Survey. The bottom quantile was poor, middle 3 were moderately rich, and top quantile was rich. We regrouped these quantiles into wealth quartiles for this study. We conducted a logistic regression to determine the association between HIV recency, socioeconomic status, and geographical location. I now present to you my findings. 70% of the recent infections detected were females. Most of the new infections, HIV infections, were among individuals under 35 years of age, and about half of the new infections were among the moderately rich. This graph shows the proportion of all newly identified infections that were recent across the regions. This proportion was lowest in central Uganda and highest in western Uganda. The proportion of newly identified HIV recent infections in this graph declined gradually from 25% to below 5% during October 2019 to November 2021, as shown by the blue line in this graph. Odds of testing positive on the rapid test for recent HIV infection were higher among females than males by 30%. Persons aged 35 to We acknowledge these institutions. I thank you.
Good evening, everyone. My name is Veronica Kembabazi, and I'm with the Makerere University Field Epidemiology Training Program. I'd like to make my presentation on the facilitators and barriers to tuberculosis case notification among private health facilities in Kampala, capital city. So tuberculosis has a high morbidity globally, with 6.4 million new cases notified in 2017 alone. These cases increased to 7.1 million new cases in 2019 and dropped because of COVID-19 pandemic to 5.8 million in 2020, and then increased slightly again to 6.4 million in 2021. Thank you. The diagnosis and successful treatment of people with TB averts millions of deaths each year. However, we continue to notice large gaps in its detection and treatment, especially among private health providers in low and middle income countries. Many of these providers are not linked to the national TB and leprosy programs, and recent literature has shown that these private health providers tend to be associated with inconsistent practices in diagnosis of TB, which also increases the risk for delayed TB diagnosis and the development of drug-resistant TB. Therefore, we set out to assess the facilitators and barriers to TB case notification among private health facilities in Kampala. TB case notification can be described as the process of screening, diagnosing, and reporting new TB cases and presumptive TB cases. So we set out to describe the TB case notification practices by health workers in private health facilities in Kampala, capital city. We also wanted to assess the facilitators of TB case notification as well as the barriers to TB case notification among private health facilities. Our methods. The study area was Kampala district, which was selected because of the high private facility attendance, and also being an urban area with congestion, it has a high TB burden. Our study population were the private health facilities in Kampala. And we targeted the clinics, health center 2s and health center 3s from 3 divisions. As you can see from the figure, this is the map of Kampala City, and we have the 3 divisions, Kawempe, Nakawa, and Kampala Central. Okay. So for our methods, this was a cross-sectional study where we used a mixed methods approach and applied concurrent triangulation. The sample size was estimated using Kish-Leslie for the quantitative arm, and qualitatively, we used purposive sampling to come up with 13 in-depth interview participants and key informants. For the quantitative arm, we used stratified random sampling, and qualitatively, as I earlier said, we used purposive sampling. 3 key informants from the National TB and Leprosy Program staff and the Kampala Capital City Authority TB and Leprosy focal persons, and 10 in-depth interview participants who were TB focal persons from the facilities we studied. Our outcome variable was TB case notification among private health facilities, and this was a binary variable. Data was collected, capture tools, the quantitative data, analyzed in Stata, and we used modified Poisson for multivariable analysis to obtain prevalence ratios. Qualitatively, we used Atlas TI to identify common themes relating to TB notification practices and the facilitators and barriers to TB case notification. Our results. We involved 224 facilities in this study, although we visited 238. Majority of them were from Nakawa division, and the majority of TB focal persons who were interviewed from these facilities were nurses. Most of the facilities noted that they did not have TB case notification tools to notify TB cases, and also 89 of them lacked guidelines for screening TB at their facility. So here we have a figure that represents the proportion of facilities notifying by division. We can see here that a majority of those that do not notify TB cases come from Kawempe division. And then on your right, you can see the distribution of notification by facility. About the TB case notification practices, the health workers reported that TB case notification was a mandatory policy, not limited to public facilities. And then the key informants also noted that all facilities were expected to screen for TB and refer the presumptive TB cases or the samples where they did not have diagnostic facilities. As one key informant states here that the majority of private facilities actually don't offer the core cascade on TB, but at least we decided to give screening. They further went ahead to note that various cadres and facility staff were involved in the process of TB notification, especially screening. Further analysis showed that higher TB case notification among private health providers was associated with all staff at the facility being involved in screening and triage. They also, most of the TB notification practices, that is screening, diagnosis, and reporting, were generally in line with policy, with a few inconsistencies, especially in reporting. As one TB focal person states here that reporting is supposed to be monthly, but for us here, we do it after 2 weeks so that we simplify data analysis for the focal person. Facilitators of TB case notification. Regression analysis didn't show the prevalence of TB case notification to increase with any of the predictor variables. However, in our interviews, the focal persons noted that the need for regular supervision, dialogue, and engagement activities really facilitated TB case notification. Also, the provision of motivators like airtime and funding, provision of TB tools, guidelines, and IC materials and diagnostics, regular private facility tuberculosis continuous medical education activities, and digitization of TB reporting reduces the burden associated with paperwork. So as you can see here, a quote from one of the key informants on regular supervision. We need to orient them, that is the staff in private facilities, regularly on new developments because we change tools all the time. As we go probably to supervise public DTUs, we should be able to supervise the private. And the barriers, TB case notification. Regression analysis didn't show prevalence of TB case notification to decrease with the lack of, regression analysis showed prevalence of TB case notification to decrease with the lack of guidelines, with the facility division, the division in which the facility is located, and also with the absence of training for the staff in that facility. They also mentioned from the interviews that patient confidentiality and TB stigma among patients and health workers was a key barrier to TB case notification. Inadequate support for TB notification processes, such as lack of funding and airtime, then missing data in the TB case notification tools, health system delays in diagnosis, especially turnaround time for the samples that are sent for diagnosis, and then high turnover of staff or lack of training in diagnosis and filling of TB reporting tools. The limitations of this study, we only studied facilities that were registered by the Ministry of Health, so we missed out the chance to look at facilities that were not registered. And then data was collected, data on TB screening, diagnosis, and reporting practices was self-reported, which also could not be controlled for using the observation method that we did not employ. Conclusion, TB case notification is mandatory for private facilities as well. Private health providers may not be up to date in the referral and reporting processes in line with the changes from the National TB and Leprosy Program. Public-private mixed mechanisms proposed by the World Health Organization have not been fully utilized in Kampala. And lastly, barriers that have been identified can be mitigated with support supervision, training and engagement activities, which are also identified as facilitators. We recommend that the National TB and Leprosy Program allocates more resources towards public health provider supervision and training, and that they explore and utilize public-private mixed models to increase TB case notification. Training of public health providers should target nurses and clinical officers, especially in the TB hotspots.
Veronica, round up, please.
Private health providers can leverage upon regular private facility, continuous medical education, as the National TB and Leprosy Program works towards increasing supervision and engagements. And lastly, private health providers with higher TB case notification numbers reported in DHIS2 can be targeted for case finding support and TB rapid molecular testing equipment. Thank you very much, and have a good evening.
Can't I use this part? Okay. So good evening. My name is Emily Kurera from the Kenya Field Epidemiology Program. I'm going to present my study on the factors associated with the use of directly observed treatment therapy among tuberculosis patients in Mombasa County, Kenya. So tuberculosis is a disease caused by Mycobacterium tuberculosis bacilli. Tuberculosis still burden in 2019 globally was at 10.4 million cases with approximately 1.5 million deaths. Africa accounts for 25% of tuberculosis cases globally. Kenya, the burden of TB is at 558 per 100,000 population. Cases notified in 2020 were 86,504 and a death rate of 7%. Mombasa County has a high tuberculosis burden of 861 per 100,000 population. This is high compared to the Kenya's TB burden, despite those being implemented.
directly observed treatment strategy is the gold standard for active TB treatment. So what is directly observed treatment therapy? Directly observed treatment therapy is a key element for tuberculosis case management. It entails tuberculosis medicine being swallowed by a tuberculosis patient under the observation of a trained healthcare worker or a community health promoter. DOTS ensures that proper medications are given at proper intervals and at the right doses. Given the high tuberculosis burden and the risk of multi-drug-resistant tuberculosis, understanding the factors associated with the use of directly observed therapy is of public health importance for Mombasa County. So our objectives for the study was to determine the socio-demographic characteristics of the tuberculosis patients on directly observed tuberculosis therapy in Mombasa County, to determine the factors associated with the use of directly observed therapy among tuberculosis patients in Mombasa County, then to explore the lived-in experiences of tuberculosis patients while on directly observed therapy. So our methods. So the study site was Mombasa County. It has 6 sub-counties. The county population is at 1.2. About 60% of the people live in overcrowded informal settlements. Then the study was conducted in 8 health facilities in the county. Our method, our study design, it was a mixed, we used the mixed methods approach with a qualitative and a quantitative methods applied. Our inclusion criteria was tuberculosis patients aged 18 years and above, residing in Mombasa for at least 1 year. Then tuberculosis patients on tuberculosis care for 2 or more months during the data collection period. Then healthcare workers working at the tuberculosis clinics who monitor, follow up, and do drug refills for the tuberculosis patients. Our exclusion criteria was tuberculosis patients who were sick and were not able to respond to the questions or were mentally incapacitated. So data collection and analysis. For the quantitative part of the study, we used a structured questionnaire. For the qualitative part of the study, we conducted focus group discussions and key informant interviews. Data was analyzed using Microsoft Excel and EPIMPO version 7.22. For the descriptive analysis, means and standard deviation for continuous variable, proportions and frequencies for categorical variables. For the bivariant analysis was performed to analyze the factors associated with the utilization of directly observed therapy. Variables with p-value of less than 0.2 in the bivariant analysis were included in the multivariant analysis. Backwards elimination logistic regression was used to identify the independent factors using the chi-square test. Factors with a p-value of equal to or less than 0.05 were considered statistically significant. So for the qualitative part, that's me doing the key informant interview with the nurse and our focus group discussions at the health facilities. Our results for the socio-demographic characteristics, we see that the males accounted for 60%, then tuberculosis patients aged 25 to 35 years accounted for 38.2%. Then for the type of patient, new patients, for the type of TB, drug-sensitive TB patients accounted for 90.5%. Then categories of patients, the new patients accounted for 82.1%. For the bivariant analysis, we had several factors, but we remained with 3. That was, does the DOT provider counsel the patients on TB treatment and side effects? The DOTS providers inquiring about the patient's progress and health education. Then how are the TB patients treated in the community? So those with a p-value of 0.02 and below were moved to the multivariant analysis. So does the DOT provider counsel you on treatment and side effects had a p-value of 0.019, which was statistically significant, and the DOTS provider inquiring about the patient's progress and providing health education had a p-value of 0.002. So for the qualitative part of the study, healthcare workers providing health education on that point, those providers counseling patients on tuberculosis treatment, side effects, and inquiring about the patient's progress were identified as the factors significantly associated with the use of dose. During the focus group discussions, patients mentioned not being provided with regular health education at the health facility, especially on busy clinic days. For the first respondent, we are not provided with regular health education regarding tuberculosis direct observed therapy. The nurse just advises us to attend clinics and avoid being late. If you are lucky, you get information when you go for your second visit. TB patients also complained over TB drug side effects and how it has affected their lives. And the second respondent said, the medication made me very sick. I could not control my balance. I got tired of going to the clinic. Sometimes I thought of stopping the treatment. Then on the tuberculosis side effects, tuberculosis patients mentioned loss of employment due to tuberculosis medication, thus being financial burdens to the family members. While the third respondent said, I work as a daily laborer. I lost my job because I was feeling weak, severe joint pains. I was admitted for a month and spent all my finances. I depend on families and friends for support, which makes it so difficult for me to focus and continue on my treatment. TB patients interview mentioned stigma and loss of support from family and community as factors affecting dose utilization. The fourth respondent said, I feel uneasy while going to the test clinic. In case someone sees me, I wake up very early to go to the nearby clinic. Another one said, even if people are doing their normal activities, I feel like they're looking at me carrying a pack of drugs, so I hide it in my bag. So for the health survey factors, this is the key informant. The healthcare workers reported the challenges they face as they give dose to the TB patient. The first key informant said, once a TB patient feels strong, they rarely or never show up at the chest clinic based on my experience. I feel that there's a big challenge of substance abuse in the community and very little knowledge on handling such cases. The second key informant said, I have worked in the TB clinic as a focal person for the last 5 years. Most patients are drug addicts and know little about tuberculosis and directly observed treatments. Others do not even care when talking or giving health talks during the clinic's days. The third key informant said, patients easily default and cannot even be traced in the community by the community health promoters. It's scary and unsafe to visit them in drug dens to convince them to take anti-TB medication. So in conclusion, the factors associated with the use of directly observed treatment among tuberculosis patients in Mombasa County were healthcare workers counseling and providing health education on tuberculosis and tuberculosis drug side effects to the patients, healthcare workers monitoring the progress of TB patients on dose and stigma. So recommendations was comprehensive and continuous health education by healthcare workers on tuberculosis and TB drug side effects to the patients at the health facility, continuous monitoring of TB patients' progress by the healthcare workers to encourage community to visit health facilities for proper TB diagnosis and treatment. Then community health promoters to educate patients, family members, and the community on TB. So after the dissemination of our results to the county, the public health action was the daily health education at the health facilities started by the healthcare workers and the community health promoters on DOTS. Hence, there was a reduction of the tuberculosis negative treatment outcomes, such as the treatment failures. The community health promoters trace patients lost to follow-up and treatment defaulters in the community to ensure the successful treatment outcomes, that is cured, completed treatment for TB. And also, there is an improvement in the treatment success rate in Mombasa County. It's currently at 88% from the 83% in 2019. TB services are accessible and free in all government facilities in Mombasa County. I acknowledge the following. Thank you.
Let me see if it's working. Just use this one too. This one? It's not projecting. It's not moving? No, it's not projecting here. No, they will project. Just go back. No, I'm talking about the here. No, they will not do it. That one will not do it. Okay.
Good evening. My name is Vincent Ganu from Ghana. And I'll be presenting on C-reactive protein levels in patients initiating dolutegravir-based regimen in Ghana. HIV is a viral infection, and we know for the past 40 years it has transitioned from being an acute deadly condition to now being a chronic manageable one. And why has this been possible? It's because there's been significant advances in medical when it comes to the medications. And one of these new medications that we are talking about now is dolutegravir, which the WHO recommended that all countries should try to integrate into their HIV programs as first and second line since 2019. Now, though HIV is a chronic condition now, we still have deaths occurring within this population. But if you look at the data critically, you realize that these deaths are not AIDS-related deaths, but now we have most of them being non-AIDS-related morbidity and mortality. Now, this non-AIDS morbidity and mortality has got a lot of issues, underlying mechanisms, and one of the major mechanisms is inflammation. Now, this inflammation is caused by the HIV virus itself and some of the antiretroviral medications. However, most of the antiretroviral medications that are existing now are able to reduce the inflammation. However, they don't bring it to the normal level when you compare it to the uninfected population. So once you have this happening, you have the HIV infection causing an increase in inflammation, and which increases the inflammatory markers in the body. And once the inflammatory markers go up, we put these patients are at excess risk when you compare them to the uninfected population of developing non-communicable diseases, especially cardiovascular disease. Okay, so one of the best ways of assessing inflammatory markers is using the C-reactive protein. And the C-reactive protein is what we use in our study to indicate the markers of inflammation. Once Ghana was starting to introduce dolutegravir, what we wanted to find out is, will this new drug contribute to the excess risk which is already existing in this population, or will it remain the same, or will it reduce that excess risk? And so because it was the first time being introduced in Ghana, and there are limited studies on the effect of dolutegravir on inflammation, we decided to conduct the study to determine the change in the CRP levels and the risk factors associated with abnormal CRP among patients who were initiated on the dolutegravir regimen. So we conducted a prospective multi-center observational study in 5 high-burden areas, which were in 3 regions in Ghana. That's the Greater Accra, Eastern, and then Western region. The study was conducted over a 2-year period. That was from August 2020 to September 2022. We involved adult patients 18 years and above who were initiated on the dolutegravir. Either you were a new case being initiated, or you are an old one which is being transitioned because of the policy, the Ghana policy to transition everybody onto it. Now, what we did was to administer questionnaires. We followed each patient up for 18 months, and we administered questionnaires. And questionnaires were administered at every study visit. And the follow-up times were at baseline, when you are recruited, at times 3, 6, 12, and 18 months. Now, at each visit, including baseline, we had blood samples being taken, and we're measuring your CRP levels as you are taking the dolutegravir. Now, for the operational definition for the study, your normal CRP was defined as less than 5 milligram per deciliter, and then the abnormal CRP was defined as greater than or equal to 5 milligram per deciliter. So for our analysis, we used data, and then we calculated the incidence rates and also the person time, and the incidence rate was reported in person months. We also calculated the hazard ratios as well. We obtained ethical approval from the ethics review committees of the Ghana Health Service and Kolebu Teaching Hospital, and also obtained rating consent from the patient. Now, we screened a total of 3,682 patients over a 3-month period. And of them, we found out 21 were pregnant women. Now, they were excluded because pregnancy also contributes significantly to inflammation. And so we had to exclude them. When we excluded them, we were left with 3,661. Of these 3,661, we realized 961 had abnormal CRP. That is values greater than or equal to 5 milligram per deciliter at baseline. And then 2,700 were normal. 73% of our patients were female, a mean age of 46.5 plus or minus 11.8. And 91% were already ART experienced. And 93% who were ART experienced were on a efavirenz-based regimen. The overall incidence rate of abnormal CRP levels was 23.7 per 1,000 person months. What we did find out was that for those who had abnormal CRP levels at baseline, that's the 2,700, throughout the 18-month period, we realized that their mean CRP values remained the same and did not change. It still remained within the normal ranges. Now, for the graph on the left, this graph is for those 961 who had abnormal CRP levels at baseline. You can see from the graph that at time 0, which is baseline, their mean CRP was 9.2 before they were started on dolutegravir. But as time went by, you realize that it reduced significantly into the normal values of less than 5 and remained the same even as at 18 months. So for the risk of developing abnormal CRP levels, what we found out was that those who were ART experienced had a 32% reduced risk of developing abnormal CRP levels, and those with comorbidities had a 14% increased risk of developing abnormal CRP levels. So in conclusion, we realized that patients who were started on DTG and who were normal at baseline had no significant mean increase in their CRP levels as time progressed. And those who were ART naive or had comorbid condition had higher risk of abnormal CRP levels, which increased their risk of cardiovascular diseases. So our recommendation is that all national AIDS and STI control programs of countries should ensure that patients who are ART naive are quickly initiated on DTG regimen to reduce their risk. And then clinicians should also screen patients, HIV patients, to ensure that those with comorbidities are managed comprehensively to reduce the risk of high inflammation. We shared this information also with our National HIV Control Program, and as at now, they are encouraged by this, knowing that it does not add on to the excess risk, and are transitioning everyone. And currently, even the children would also be transitioned also onto DTG as well. Thank you very much.
We thank all 4 presenters for great presentations and keeping up with the time. So now I open the floor for the questions. Of course, it's a practice. You introduce yourself. You indicate to whom are you targeting your question. And let's try to be conscious. The time is not on our side. Okay, starting with Dr. Carl.
Thank you so much, Carl Reddy, AFENET. I would just like to know from the first speaker what the drivers of recent HIV infection were, and was there implication of sugar daddies, as previous studies in Uganda have demonstrated. And then for the second speaker, I'd like to know what are there, if any, health regulations that compel private facilities to notify TB? Are they not bound by health regulations to notify? Thank you.
Thank you. My name is Salomon Kovil. I'm a medical epidemiologist. I'm working for AFENET. The first question is going to the first presenters. In your result, you show that age group and socioeconomic factors like some to be rich are protectors factors. Can you discuss a little bit more on that? Because I just presented the finding, but I will not see any discussion about that. Or can you explain those factors can be like protectors factors for recent HIV? For the second presenters, thank you for presenting the finding on qualitative and quantitative data on your research. But since you have been conducting this study, have you taken some public health action? If yes, do you have any changes based on those public health action? Thank you.
Thank you very much. My question is directed to the fourth presenter. And I'd like to find out from him, there are a number of inflammatory markers, but I want to find out why in his study they settled on C-reactive protein. Thank you.
Anyone with a question to presenters? Okay, I'm seeing the hand there.
Sorry. My name is Nangoma from Zambia. I have a question for the fourth presenter. I saw there was an increased risk of C-reactive protein in those ones with comorbidities. I wonder if you can share more light on what kind of comorbidities you looked at, because they are quite a large spectrum. Thank you.
Thank you. Let me ask Emily. I just want to understand, in your studies, how was the side effects related to the job loss? Because you indicated they were in your quantitative result that one patient indicated he was hospitalized over a month. I might have missed if this admission was because of the side effect, because you related it now to the job loss. Thank you. Let's give a chance to our presenters, starting in the sequence as you have presented, to address your questions. Thank you.
Thank you very much for the questions. The first question was asking about drivers of recent HIV infections in Uganda. However, the gentleman who asked the second part of the question, I did not hear it well. If you could kindly ask again.
Thank you. So it was about, yes, you're right, the drivers for HIV infection, recent infection, and whether the drivers included sugar daddies.
Okay. Thank you very much. So the drivers, or I could say the study was looking for factors associated to HIV infection, and we got that being female, being adolescents, and also being female and adolescent were associated with new infections. And yes, one of the highest risk factors of HIV infections, including the recent ones, is the risky sexual behavior. And many of the adolescents and the people we categorized as poor sometimes have transactional sex. And this transactional sex is meant to exchange sex for money so they can survive. So that's how it becomes a risk factor. So yes, the sugar daddies could be involved. And maybe the next question, why rich are protective? The wealthy status seemed protective in our study. we realized that, like I mentioned earlier, many of the people who are categorized as poor also have risky sexual behavior. They exchange sex for money, to survive, to eat, and so they end up sometimes contracting HIV/AIDS. However, the people categorized as rich are able to take care of the children and also themselves, so they are at a lower risk. It's not that they cannot get the infection, but they are at a lower risk of getting the infection in that way. Thank you very much.
Thank you all for listening. I'd like to address 2 questions that were posed to me. And the first was about private facilities being bound by regulation to notify. Yes, the year prior to this study, that was 2021, the Director General of Health Services issued a communication obliging all facility heads to ensure that they do TB case notification. But as you can imagine, a good number of facilities are not registered, the private health facilities. So it's very hard to track and be able to enforce these communications and regulations by the Ministry or the National TB and Leprosy Program. Yeah. And then the second question is about if public health action has been taken based on the results. Well, prior to this study, the Director General of Health Services issued this communication. And well, following my study, I'm not aware of any action that has been taken to oblige the private facilities to work on their TB case notification. But I know that there are efforts that are being made to improve their engagement, to facilitate their notification, for example, linking them with public facilities for those that lack diagnostic facilities, so that if they cannot diagnose at their facilities, they can refer the samples, for example, or they can be linked to the Kampala City Council TB focal persons to provide them with what may be lacking. So such efforts are being made, and some of them also by implementing partners. Yes. I have not really observed any changes, but probably we can do some further studies to see if there's an improvement in this. Thank you.
So thank you for the question. It was about the side effects and loss of employment. So for the first respondent, I think he was a casual laborer, which means you go to work, you're paid for that day. So if you do not show up for work on that day, someone else picks your job. So for him, the side effects made him not go to work and did not have some money for that, did not get paid for that day. Thank you.
Okay, thank you very much. I think I'll start with the second question. Yes, so the comorbidities observed in our study were mainly hypertension and diabetes. For those that had comorbidities, 96% of them had diabetes and hypertension. And so those were the main ones. And so that's what we're referring to. For the first question, yes, clinically there are about 3 types of biomarkers for inflammatory, measuring inflammation. So we have the C-reactive protein, we have what we call the erythrocyte sedimentation rate, which is the ESR, and then we have what we call the procalcitonin. However, the procalcitonin is usually used to monitor bacterial infections. HIV here, we are talking about a viral infection, so that one is out. So we are left with the ESR and then the CRP. However, when you look at literature says that the CRP is a direct measure of plasma proteins which are produced in response to inflammation, whilst the ESR is an indirect measure, because for the ESR, they take the blood, they put it in a tube, a designated tube with some chemical, and then they watch how the blood falls, and then they use it. However, the blood falling has issues because it can be affected by the number of red blood cells, the size of the red blood cells, and even if somebody has a kidney problem, it affects the ESR. So then if you want to look at the two and you want to get a more accurate measure, you go for the CRP. Again, with the CRP, you see the inflammation is a response to an infection. So once you have an infection in, the CRP rises within some few hours. And then it will go down within 7 days when the infection is off or whatever is causing it is out. However, the ESR takes time to rise up when there's an infection. And then once it rises up, it stays there for quite a long time. It can be there for months before it comes down. And therefore, when the infection is no more there and you even measure using a ESR, it will tell you the inflammation is still up. And because of these differences, this is mostly preferred that we use the CRP compared to the ESR. Thank you very much.
Another round of applause for our presenter for addressing those questions. Thank you very much. We exchange now the podium. This group will go back to become audience. Then we welcome the last set of presenters, Jonathan, who will be presenting to us an analysis of childhood tuberculosis notification and treatment outcome incident rate ratios in Zambia. He will start here on my immediate right. Kizito will follow, who will be presenting factors associated with mortality among TB HIV co-infected patients with drug susceptibility in Rwanda, a cross-sectional study. Then Folake will present rifampicin resistance and determinants in TB patients attending clinics in Abeokuta, Ogun State. I was informed that Hamad is not here, but we have a video which will follow. We might not get chance to ask him questions because he's not connected. So as we did with the previous set, we'll start without interruption in between. Then I'll only stand when I give chance for the audience to ask questions.
Oh, I have to die. Okay, sorry. Good evening. My name is Jonathan Punduchama. At the time we were doing the analysis for this study, I was a resident, but now I'm a graduate of the Zambia Advanced Field Epidemiology Training Program attached to the National TB Program in Lusaka. So I'm here to give a presentation on an analysis of childhood tuberculosis notification incident rates, ratios in Zambia between 2016 and 2021. That's the outline of my presentation. Beginning with the background, tuberculosis is the second leading cause of, the second leading cause of infectious killer diseases after COVID-19 and above HIV and AIDS. Children who are less than 15 years contribute about 11% of the global TB cases. In Zambia, as of 2020, the TB incidence was estimated to be at 333 per 100,000 people population, and children consisted 7 to 9% of these numbers. Zambia did a trend analysis on childhood TB last in 2013, which showed a declining trend between 2004 and 2013. However, there's been an evolution of the population structure as well as distribution, and there's been in recent years a renewed focus on childhood TB. So this trend analysis really was designed, or is likely to inform future interventions and resource allocation by highlighting areas that require focused attention. So the objective of our study was to describe trends in childhood TB notifications and identify various factors that may make somebody more susceptible to TB, that is childhood TB, and then explore some effects of the previous interventions on the trends. So we analyzed data from the National TB Program, that is TB surveillance data between 2016 and 2021, and we reviewed some policy documents and guidelines at the Ministry of Health to understand previous interventions in childhood TB. And then during our analysis, we checked for excess zeros in the data, which is basically case counts, and we also tested for over-dispersion. We actually found that the data was over-dispersed, and because of this, we proceeded to fit a negative binomial count model to investigate the incidence rate of childhood notifications, and we adjusted for sex, the age, the type of TB, the site of TB, and the year. Incidence rates ratios were considered to be statistically significant at 0.05 p-value. In terms of the results, what we see really is that between 2016 and 2020, there was somewhat a stable kind of notification counts and a spike in 2021. We are reporting absolute numbers in line with the reporting system for WHO. These graphs are basically just showing how these cases were diagnosed. So we are saying that most of the cases were diagnosed through clinical diagnosis, which we see in both age groups. We have 0 to 4 age group, which is at the top. The top two graphs there represent 0 to 4. The bottom two represent 5 to 14 years age. And what we see that in both age groups and across both sexes, we see that most of the cases were clinically diagnosed. All right, thank you. The next slide is showing the type of TB disaggregated according to pulmonary versus extrapulmonary, and we see here that most of the cases were actually pulmonary cases, and there was actually a declining trend for extrapulmonary cases. We also analyzed data across all the provinces in the country, which are about 10, and we were able at least to see a pattern in terms of the trends. What we saw was that most of the provinces were showing a similar trend in terms of increasing trends across the years. This slide is showing a number of interventions that were implemented by the National TB Program to try and improve notification rates for children. So you see that in 2016, where there was an introduction of gastric lavage and nasopharyngeal aspirate as samples. And then in 2017, some training was undertaken in the country. 2018, there was further introduction of other testing modalities. 2019, further rollout of these modalities. And 2021, further training in sputum induction took place in 12 facilities across the country, and the training was done to facilitate this process. So in order for us to understand the influence of these various categories of variables, we had sex, age group, province, year, and type of TB. We fitted a negative binomial count model, And there we see the results of the bivariate models as well as the multivariable model. We found that all the variables were actually significant, and we see among, when you consider the sex, males were more likely to be infected with TB than girl children. In terms of age group, children between 5 to 14 years were more likely to be infected, about 1.3 times than those in the 0 to 4. In terms of the provinces, there's a significant variation in terms of the incidence ratios as well, the highest being in Lusaka and the lowest being in Muchinga province. In terms of the year, we see that really there wasn't much going on, but in 2021, we see a significant jump in terms of the notification rates. In terms of the type of TB, this was also significant, as we can see there, with different contribution in terms of incidence rates ratios according to the type of TB. In our discussion, we're saying that childhood incidence in Zambia was stable between 2017 and 2020, but there was a substantial increase in 2021, which was likely to interventions by the Zambia National TB Program. Then there was a high incidence of pulmonary cases versus extrapulmonary cases, something which aligns with the global trends where pulmonary cases are more common than extrapulmonary cases. But we also noted that there may be possible underreporting and underdiagnosing of extrapulmonary TB in children, owing to the fact that it's not very easy to make a diagnosis of extrapulmonary tuberculosis in children. And then there was a more than threefold increase in pulmonary clinically diagnosed cases, which was most likely due to the fact that during this period, there were trainings that were undertaken that may have improved, that improved the capacity of health workers to make a diagnosis. Then there was an increase in the number of the incidence rates in 5 to 14 age group. Again, this also aligns with the global estimates, which estimates that incidence in 5 to 14 is much higher than in children who was between 0 to 4. However, we also noted during the review of documents and guidelines that it's possible that there may be underdiagnosis of children who are below 0, who are between 0 and 4. And then, of course, females had a reduced incidence of TB than the males. Studies among adults actually show that males are more susceptible to TB than females. And it's possible that genetic factors may be playing a role. And if that's the case, then it means that these genetic factors could also be present in children. There were also regional disparities between the provinces and in terms of incidence rate ratios, which requires further research to understand the underlying reasons. And then the interventions, we see that between 2016 and 2020, there were improved diagnostics, professional training, and expanding testing options, which we think likely contributed to the trends in the childhood and enhancing accuracy in diagnosing and reporting. In terms of public,
please, Jonathan?
In terms of public health interventions, so in terms of public health interventions, we are saying we need to focus on age-specific interventions for the age group 5 to 14, and then sustain the diagnostic interventions and invest in healthcare professional training. Limitations, time frame, would have loved to start from 2014, and then there are some variables that were not included that we are not able to, whose effects we are not able to determine, and then there was a limited scope in terms of the study. I'd like to make acknowledgements to those people that are shown there. Thank you.
Good evening. My name is Shimana Kizito from FLTP Rwanda. I have pleasure to take this opportunity to present this study about the factors associated with mortality among TB HIV co-infected patients on TB drugs accepted in Rwanda from July to 2019 up to June 2021. Those are the outlines. As you know, the tuberculosis is the leading cause of death worldwide, and Rwanda is not an exception. And as you can see, globally, 10 million people who develop TB disease. In 2019, 8.2% was people living with HIV, and 1.4 million people died from TB. And the report showed that 208,000 deaths was HIV positive. The report of Rwanda for fiscal year 2020 and 2021 showed that case fatality among people living with HIV was 15.5. Despite the effort made in Rwanda to fight against tuberculosis in terms of control and prevention, the mortality remains constantly or unacceptably higher among people TB, HIV, co-infected patients. And this study aimed to investigate factors associated with the mortality among TB, HIV, co-infected patients in Rwanda. Methods. This was a retrospective cross-section study, and for study population was TB, HIV co-infected patient registered in the electronic TB surveillance case, TB case-based surveillance, ETB, from July 2019 up to June 2021 by all health facilities reporting in Rwanda. We take all TB HIV co-infected patients fulfill the inclusion criteria and well considered in this study, and the variables like independent variables and dependent variables, which was mortality, was considered in this study. For the methodology again, data has been extracted from the electronic system and was screened in Excel and put in the starter for further analysis, and the frequency and the proportion were calculated to describe the social demographic and clinical characteristics, and bivariate and multivariate using logistic regression model well computed to measure the association between dependent variables and dependent variables. 95% confidence interval and p-value less than 0.05 were considered as statistically significant. Allow me to present the result. Looking at the distribution of TB HIV co-infected patients by age and sex, we found that the majority was female, which represents 62.8%. And when we're looking at the age group, the age group was ranging between 15 to 44 years old. Looking at the death among TB HIV co-infected patients with the drug susceptibility, this study found that the case fatality was 14.8%, and looking at the infection death by month, and we found that 85 of deaths occurred in the 2 first months. And when we are looking geographically, we found that Kigali representing 43.2%. This was the bivariate analysis. Allow me to go straight for multivariate. For multivariate, we found around 6 factors associated with mortality, such as about health facilities. We found that the patient who seek treatment at the district hospital and the referral hospital well, almost two times more likely having the risk of dying compared to those who are followed at health center. And again, BMI less than 18.5, and people clinically diagnosed was statistically associated with mortality. And again, we found that those who didn't receive the nutrition support had 1.9 times more likely having the risk of dying compared to those who received nutrition support, as well as currently those who didn't put on RT have the risk of dying compared to those who started treatment. And again, we found that those who were followed by community health workers, who didn't followed by community health workers, had 3 times more likely risk to die compared to those who started the treatment in the community. Who can help me? Okay, for the conclusion, as we said earlier, we found that this study revealed that the case fatality was 14.8 versus to the target set by NDTB strategy and the National Strategic Plan, NSP, of Rwanda, and the predictors, as we said earlier, no provision for nutrition support, underweight, BMI less than 18.5, those who have been being clinically diagnosed, not starting RT at initiation treatment, and are not being followed up in a referral hospital and district hospital, and not followed by community workers in the community, were strongly associated with the mortality. When we come back to the recommendation on that is going to stick about those findings for public health action. We recommend that to prioritize specific intervention to mitigate the burden, such as nutrition support, enrollment on RT, to newly test HIV.
Okay. Rifampicin resistance and determinants in TB patients attending clinic in Abeokuta, Ogun State, Nigeria. Okay. Drug-resistant TB is a major global threat with reference to WHO 2018 data, which 3.5% and 18% of new and previously treated cases have multi-drug resistance and rifampicin resistance TB. Nigeria is one of the 30 high-burden countries of TB, HIV, and drug-resistant TB, in which 4.3% and 25% among the new and the previously treated cases have multi-drug resistant TB and rifampicin resistant TB. Early detection and treatment of rifampicin resistant TB will reduce the emergence of multi-drug resistant TB and extensively drug resistant TB. These are my specific objectives: to determine the prevalence of rifampicin resistance in TB patients attending TB clinic in Abeokuta, to assess the determinants in TB patients attending clinic in Abeokuta, to evaluate the prevalence of rifampicin resistance and determinants in TB patients attending clinic in Abeokuta. This is my study map of Ogun State, showing where the study was done. The study was done in the state capital, Abeokuta, which housed the 3 facilities: the Sacred Heart Hospital, which is a private hospital; the General Hospital, which is a state-owned hospital; and the Federal Medical Center, a federal institution in the state. The technique for testing: a cross-sectional study was conducted, and 3 facilities, as earlier mentioned, was done between December 2022 and March 2023, and namely the previously mentioned hospitals. The study population were TB patients attending the clinic, and 275 respondents participated in the study. A convenient sampling technique was used for the recruitment of the participants, and sputum samples were collected from all the prospective patients that met the inclusion criteria. The laboratory procedures were a ZL stain method for acid bacilli was performed to culturally confirm the presence of TB. A cartridge-based nucleic acid amplification test, GeneXpert, was done to identify TB and the resistant strain of TB. I collected data using an interview-administered questionnaire, and the data was analyzed by using the univalent and bivalent analysis. Here are some of our findings. We have 100%. We have 100% compliance rate as the 275 patients attending clinic in the recruiting period participated in the study. The age range of participants was between 9 to 80, with mean age of 33.5 years. Most participants were male, 159, which makes 57.8%. Majority of the participants were rural dweller because the capital served like a referral center to other centers in the community. Okay, this shows distribution by sex of rifampicin. Okay, we have more female being resistant, having resistant rifampicin, which makes 9.5%. Then, resistant by residence, we have the rural dweller being 13.3%. Then the pattern of rifampicin resistance according to age group, we have 40 to 50% with 16.7%, being 16.7, maybe because they are likely to be active and move from one place to the other, making them being exposed to the rifampicin resistant strain of TB. This shows the previously treated with anti-TB being 9.8. Then the reason for diagnosis are 44.5%. And this shows the determinant of rifampicin. The HIV status as the odd of is the one that I just want to talk about here, as the odd of 0.08, which is 25.1 less likely to have rifampicin resistance TB. By our findings, the prevalence of rifampicin resistance mycobacterium tuberculosis is 8.5%, and it is slightly higher than the 3.2 to 5.4 WHO prediction for Nigeria. The proportion for pulmonary tuberculosis was significantly higher compared to extrapulmonary tuberculosis. The chance of developing rifampicin tuberculosis is 12.5 less likely among patients that are HIV negative than those that are HIV positive. The chance of rifampicin resistant TB was about twofold higher among patients age range 40 to 49 years than other age groups. Summary of our findings. The study shed more light on the prevalence of rifampicin resistance among TB patients. It provides valuable insight into determinants of rifampicin resistance and the importance of the need to continue effort to monitor the drug resistance. The public health action, sensitization on the need for adherence and compliance to the anti-TB drugs was done for some of the respondents that we found in the facilities, and feedback on the prevalence and determinants was given to the coordinators of TB program in the facilities. Our recommendation, efforts should be intensified by TB control program to ensure compliance and completion of treatment. Use of gene experts is advocated for diagnosis of all TB suspects. Rapid diagnostic assay to detect drug-resistant TB in order to prevent delay in treatment of multi-drug resistant TB, and the spread should be made available in all institutions by the government. These are my acknowledgements, my references, and thank you very much.
If you have just joined us, the fourth presenter is not in the room, so we'll listen to the recording of his presentation.
Good afternoon. My name is Hamad Nimbo from Tanzania. I would like to pass through you. I would like to take you through my presentation titled Prevalence of Malaria Infections and Factors Associated Among HIV-Infected Adult Patients Attending HIV Care and Treatment Clinic at Kitete Regional Referral Hospital in Tabora Region, Tanzania, a cross-sectional study. This presentation is derived from the final dissertation of advanced field epidemiology from Muhimbili University of Health and Allied Science. This is the outline of presentation. In beginning 2021, malaria globally registered 247 million cases and 619,000 deaths, of which 94% of cases and 96% of deaths occurred in Africa. The region also hosted 2/3 of the 39 million people people living with HIV globally. Tanzania faces a 7.9% prevalence of malaria and 4.7% prevalence of HIV. People living with HIV faces an increased risk of malaria infections and complications. Data on the magnitude of malaria and the associated factors among HIV patients is limited in Tanzania. Therefore, this study was aimed to assess malaria prevalence and the associated factors among HIV-infected adults attending HIV CTC at Kitete Regional Referral Hospital in Tabora Region, Tanzania. This was a cross-sectional study which was conducted at the Kitete Regional Referral Hospital from March to May 2022. A total of 246 HIV-infected adults attending the HIV CTC at the Kitete Regional Referral Hospital were selected for the study using systematic random sampling. A questionnaire was used to collect socio-demographic factors, while clinical and laboratory data were extracted from patient CTC2 card. Starter version 5.1 was used for analysis, chi-square test, binary and multivariate logistic regression, identified the associated factors. Proportion was used to determine malaria prevalence. A p-value of 0.05 was considered statistically significant. A flowchart in my right side indicating participant recruitment, whereby 246 participants were recruited for the study. 3 participants were removed from study by since they were on anti-malaria, and 1 participant failed to provide a consent. We remain with 242 participants to make a final sample size. Both participants were tested using MRDT in malaria microscope. Table number 1 indicating demographic characteristic of the study population, whereby the median age of the study participants was 49.5 with an interquartile range of 40 to 58, and majority were age 51 and above. Majority were female, and most of them were urban resident, and most of the participants had the primary level of education, and majority of the participants reported to using mosquito nets. Table number 2 indicating participant clinical history and laboratory parameters, whereby majority of the participants were HIV stage 1, and most of them had no TB infection, and most of the participants suppressed the viral load, and majority had CD4 cells greater than 350 cells per microliter, and most of them had health education on malaria, and majority of the participants had good adherence to ART. Pie chart here indicating the prevalence of malaria by both MRDT and microscope, whereby microscope is 8.3% and by MRDT is 10.7%. Table number 3 indicating the distribution of malaria infection among the study population, whereby in this study there was a significant prevalence between rural and urban resident, and non-mosquito net users and mosquito net users, similar to ART adherence, poor ART adherence and good ART adherence. Table number 4 indicating factors associated with malaria infection in the study population. In this study, rural residents, the odds of being infected with malaria was 2.81 of being infected, the odds of being infected with malaria among rural residents was 2.81 compared to urban resident, and the odds of being infected with malaria was 3.66 in participants with poor adherence compared to participants with good adherence. Similarly, the odds of being infected with the malaria was 2.8 times in participants with CD4 counts below 350 cells per microliter compared to participants with greater than 350 cells per microliter. In this study, the use of mosquito net in the health education were protective factors against malaria infections. Malaria prevalence in this study is 10.7 by mortality and 8.3 by blood smear. Malaria prevalence in this study exceeded the national prevalence of 7.9%, but it is below notably high prevalence of Tabora region, 23.4. However, this prevalence is lower than the reported that is reported in Pwani region, 29.4, in Lake Zone region, 22.4, and Malawi, 37%, and higher than 1.4% prevalence reported in Sudan. These differences could be attributed to geographical and malaria endemicity difference of the study areas. In this study, it was found that rural residents were associated with malaria infections. This could be attributed to the lower socioeconomic status, limited health access, and prevalence of mosquito breeding sites in the rural areas. These findings reveal a consistent rural-urban malaria pattern. In this study, it was reported that poor ART adherence is associated with malaria infection. In contrast, good adherence to ART is reported to improve body immunity and impact plasmodium stages. These findings suggested the role of ART in limiting malaria risk. In this study, it is reported that a higher HIV viral load was associated with malaria infection. This might be due to an increased parasitemia caused by high viral load and possible risk of malaria drug resistance caused by virus. These findings emphasize the complex HIV malaria interaction. In this study, it is reported that a low CD4 count was associated with malaria infection. This will be attributed to immunity imbalance, which lead to malaria susceptibility. Similar findings have been reported in Nigeria. In this study also, it was found that mosquito net was a protective factor against malaria infections. However, challenges such as affordability, knowledge barrier, and insecticide resistance are important to address for sustainable malaria prevention using net. Similarly, malaria health education is a protective factor against malaria infections. Hence, by integrating malaria health education into routine HIV care will improve well-being of HIV-infected individuals. We conclude by saying this study has revealed a significant concern over malaria prevalence among HIV-infected adult patients attending HIV CTC at Kitete Regional Referral Hospital in Tabora Region, Tanzania. Risk factors for malaria infections were rural residents, a lack of not using mosquito nets, poor ART adherence, high viral load, low CD4 count, and lack of health education on malaria. We recommend by saying that Ministry of Health and stakeholders should consider the following: prioritizing malaria health education during HIV CTC session, improvement of access to malaria prevention measures, specifically mosquito net to HIV-infected individuals, introducing routine malaria testing to reduce the risk of malaria in HIV-infected adults during their routine HIV CTC visits. We acknowledge Tanzania Field Epidemiology and Laboratory Training Program, Muhimbili University of Health and Allied Science, Ministry of Health, and Nyangwale District Council. Thank you for your listening and goodbye.
That was our last presentation, well delivered in time as well. I don't know if we have really clapped for our presenters. Let's clap for all of them. Thank you. Now I have an honor to open the floor for the questions. 1, 2, 3. Okay. Let's start from the middle.
Okay, thank you. Thank you to all presenters and congratulations for your presentation. I have 2 questions for the last presenters. The first one, based on your findings on a confidence interval, what are the associated factors with social demographic characteristics that you have presented? I'm asking the question and then to be careful in interpreting the odds ratio and without taking into account the interval confidence. The second one is the resistance between rifampicin and the social demographic characteristics that you have been presented. It's very interesting, but did you have a chance and then to present those findings in your country or in the regions where you have conducted this study? Specifically, and then to the clinician or the healthcare workers working for TB, and then to take public health action on that. If yes, what have you expected some impact of this study and the public health action that you have taken? Thank you.
Thank you, Carl Reddy, AFENET. My question for the third speaker on TB is, was the mortality associated with viral load and CD4 count at the start of treatment initiation? And then my question for Kizito is rifampicin resistance routinely tested for in newly diagnosed TB patients? Sorry, I got that wrong. It's for Folake, right? Is rifampicin resistance routinely tested for in newly diagnosed TB patients? Thank you.
Thank you, Joseph from Côte d'Ivoire. My question to the Nigeria's presentation: how did you select the 3 facilitators, the sampling? About the Zambia, I need some comment about the under 4 years, because in your finding you said that maybe the data was not good about the protection of the under 4 years TB. What do you think about the link with the mother's antibodies? They can be protected with those antibodies from their mothers. Thank you very much.
Okay. Thank you, presenters. These were very interesting. I think my question is actually a clarification. Maybe I wasn't paying attention. It's for, I think, my Zambia friend. You talked about the prevalence being more, of TB being more in females than males, but when the chart you presented looked like it was saying the reverse, if I observed properly, you can clarify that. And then you alluded that that's maybe the same in the children, but I didn't see any data, or what were you just projecting? If you can clarify that, that would be good. Thank you.
Thank you. I'm not seeing any other hand. But just to add the last one to Kizito, just to understand if there is any relationship between the months, the period of the year, and the death occurrence, because I indicated there were some months when death were most predominant as compared to other periods. The responses will follow again the sequence as you have presented. Then you tackle all the questions which were posed to you. Over to the presenters.
Thank you very much for the questions. Concerning the incidence rates ratios in children between 0 to 4 years, what we found was that the rates of notifications in these children is much lower than those between 5 and 14. And from literature, what it says is that, first of all, in this age group, the 0 to 4, it's very difficult to make a diagnosis of TB. So it's likely that there is underdiagnosis, as well as these children being missed. So that may be a contributing factor. But the global trends is that children between 5 to 14 years actually are the ones who are more susceptible than those between 0 to 4. So what we found in Zambia during our trend analysis was that it was consistent with that global trend, but then we also realized that there may be issues of underdiagnosis that may also be contributing to these lower levels of TB in children between 0 to 4. To answer your question specifically with regards to protection against maternal, by maternal antibodies, it is possible, but from what I understand, in terms of immunizations, TB is one of those diseases where children are immunized very, very early. Probably because maternal antibodies may not play such a significant role. I'm not an expert in immunology, but I'm just extrapolating from the little knowledge that I have on that. And then in terms of males being more susceptible, so the graph that I showed was actually showing that females, the incidence rates ratios in females are about 13% lower than in males. What that means is that males are actually more susceptible to TB than females. So that was what my graph was showing. So there was no literature that was speaking to the reasons why it is like that. But in adults, studies have shown that males are more susceptible than females. And there's been some postulation that there may be genetic factors at play to explain that sexual dimorphism. But then if it is genetic factors, then it's likely that these genetic factors are actually present even in children and may be playing a role.
Okay, thank you. The question asked about relationship with mortality. When we are looking about we say that the 85% of death occurred in the first 2 months. This was a description of. It was just during the description. We didn't be able to measure the relationship. So that's why we recommended to conduct further research that may use survival analysis, which is taking into account looking the time and event. So this was a limitation for the study. We didn't measure the relationship with the different months. When we are looking for the month 3, we are seeing death. It was about 6%. Month 4 was 4%. But in terms of measuring the factors associated with the mortality, we didn't working on that. We are just suggesting, as I said, to conduct survival analysis. Thank you.
Okay, thank you very much. So some of the association factors there were found out to be level of association between the rifampicin resistance and some of the factors like age. We discovered that the age between 40 to 49 there is an association between rifampicin resistance and age. Then pulmonary TB and the extrapulmonary, we discovered that we have higher percentage with the pulmonary TB. Then the rural dwellers too. These are some of the associations we found that that has association with rifampicin resistance. Then another question on the public health action that was taken. Of course, the feedback on our findings was communicated, like I said, to some of the respondents were sensitized, and the clinicians too, which are coordinators of most of the TB programs in the state. But the impact has not been, the impacts was not mentioned, but the result, the outcome of the study was communicated for them to take a public health action. Then, for the question that newly diagnosed TB, yes, because as most of our facilities, when you come, we take sample and diagnosis is being done for the presence of TB because we use GeneSPAT, and GeneSPAT diagnose the presence of TB and also the presence of rifampicin resistance TB. Thank you. I don't know if I've answered all the questions.
Thank you. If there is an omission on a question which is not fully addressed, the presenters are here throughout the conference. We can reach them. Hopefully tomorrow we need to rest tonight. With that, we have reached the end of our session. I really thank all of us, the presenters, evaluators, our vibrant room manager, for being on the tour to manage the slides, and the IT team. And sincere appreciation to all of you, the audience, for being here with us till this hour. I know it had been a long day. Thank you for endurance. So let's then clap for ourselves, all of us, and have a restful night. See you tomorrow.